بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه الغر الميامين. أعزائي إخواني أبنائي الطلبة، أحييكم مجددا ونلتقي في الجزء الثاني من محاضرة الميكروبيال keratitis. In the previous lecture we finished discussion about the bacterial keratitis and some other forms of keratitis like the microsporidial keratitis, pythium keratitis and acanthamoeba keratitis. Now in this lecture we will discuss about two important causative organisms of infectious keratitis, that's fungal keratitis and herpes simplex keratitis, or herpes as a general. And also we will discuss important two studies in this regard, which is the MUT studies, that is mycotic ulcer treatment trial, and the herpetic eye disease study. This is very important for you as a postgraduate and as clinicians. So as usual, I will try to simplify things for you and give you the pros and cons for each item. And I hope that you will enjoy this lecture, and let's dive deeply and see what's there. Thank you very much. Now we come to the second most important cause of infectious keratitis after bacterial keratitis is the fungal keratitis. Now we will discuss different types of the fungal keratitis, different varieties, the aspergillus, the fusarium, and the candida keratitis, and we will discuss the different studies like the MUT studies, that's the mycobacterial ulcer treatment trials for the management of fungal keratitis, and the new modalities in the management of fungal keratitis. Now we come to an important cause of infectious keratitis, which is known as the fungal keratitis, or also named as mycotic keratitis, abbreviated as MK. Now, although the infectious keratitis is a leading cause of monocular vision loss all over the world, still the mycotic keratitis remains one of the main cause of ocular morbidity and opacification, and a cause of preventable blindness, because the fungal keratitis accounts for about 5 to 10% among infectious keratitis, and especially common in tropical and subtropical climate countries. And it is proposed that the frequency of mycotic keratitis is more in the developing countries as compared to the developed countries. And the main reason in the developing countries is due to trauma. However, the contact lens wear is the main cause in the developed countries. And for accurate treatment and prevention of mycotic keratitis, early diagnosis and treatment is very crucial, because of it carries a high morbidity in the delayed management. It has a high risk of melting and perforation and even endophthalmitis, and also due to the poor penetration of the antimycotic drugs inside the deeper layers of the cornea, and the mixed clinical signs and symptoms that may mimic a bacterial or viral keratitis make it one of the reasons of the delay in the diagnosis. Now, if we look to the classification of the fungi that's causing the mycotic keratitis, based on the cellularity, which is the filamentous fungi, which is the multicellular one, and also named as molds, and those with unicellular organisms is the yeasts. Now, the filamentous fungi or the molds can be further subdivided into those with septae, that is making the hyphae, and those without septae is called non-septated organisms. Now, the one which is most important causing mycotic keratitis in the septated hyphae is the Aspergillus fumigatus and the fusarium, which is very important cause of mycotic keratitis. Now, the non-pigmented organism or the non-septated organisms is the most common is the mucormycosis, which is or the mucor. The mucor does not cross the corneal epithelium, but it causes orbital cellulitis, as you know. So this is the multicellular type of fungi, and the unicellular type of fungi is the most common is the Candida albicans. Now, there is another entity which is called the dimorphic fungi. This dimorphic fungi, it is exhibit the property of both the yeastis at particular temperature as a unicellular and molds and at another temperature. The most common is the cryptococcus. This is not causing a ocular infection, but it causes other infections in the brain and in the lungs. So for us and for the spectrum or the scope for this lecture, we will concentrate in the filamentous fungi, mainly the Aspergillus fumigatus and the Fusarium, and the yeastis, namely the Candida, because they have different clinical presentations, and also the spectrum of antifungal treatment differs between different drugs to cover these type of organisms. Now, if we have a quick look to the risk factor and the predisposing factor that lead to fungal keratitis, we will find that the use of contact lens wearers and the trauma is a common risk factor, especially, as I said, in the developed countries. The extensive use of contact lenses has increased the incidence of fungal keratitis. Also, the incidence of trauma or the risk of trauma is more in developing countries, so the prevalence of mycotic keratitis is increasing. Another important cause is the chronic ocular surface disease problem. This is very important. Any presence of any chronic ocular surface problem, this is predisposes the patient to the fungal keratitis, especially those with chronic conjunctivitis and those with dry eye. So you should be careful about these cases. In cases of chronic keratitis, immune suppression, corneal anesthesia or abuse of topical anesthetics. Also, chronic use of broad-spectrum antibiotics. This is very important because it is very important. It is found that the commensal organism that's present in the cul-de-sac and in the conjunctiva plays an important role as antifungal agents. So when you have a chronic use of antibiotics, so you get rid of the antifungal effect of the commensal organisms. And this has been found in those people who are on a prolonged antibiotic for a long time, especially people with prosthetic ocular prosthesis. So in these patients, they need to use the antibiotic lifelong, so they are at risk of fungal infections. And also prior corneal surgery, namely keratoplasty, is very important because they have combination of ocular surface problem as well as chronic use of steroids and the corneal trauma with the soil or organic matter. This is an important source of contamination. Another systemic risk factors is diabetes mellitus and immune suppression like HIV and leprosy. This is general risk factors for the fungal keratitis. Nowadays, the incidence and the prevalence of fungal keratitis is increasing because of the advanced and the extensive use of contact lenses in the developed countries. Even now in the developing countries, they start using the contact lenses, especially the cosmetic one, and also the extensive use of steroids as well as the trauma. If we look to the pathogenesis of fungal keratitis, as we insist always that the precipitating factor of trauma is very important to initiate a inflammation due to fungal keratitis because the organism itself cannot penetrate intact epithelium. So once there is a evidence of a trauma or defect in the epithelium, so at that time the organism will gain access to the stroma. And once enter the stroma, it will multiply and proliferate inside the stroma and release mediators and proteases and collagenases that melt the adjacent structures and causes necrosis and severe inflammations. And sometimes also it can able to penetrate the descemet membrane without causing perforation. So once the penetrate the descemet membrane, it will gain access to the anterior chamber and can cause endothelial plaques, and you will find the hyphae and the organism itself inside the anterior chamber. So that's why the hypopyon in the fungal ulcer is not sterile, it is septic because it is contaminated with the hyphae and the organism itself. This is the main pathogenesis precipitated by corneal or epithelial erosions. Now, if we look to the clinical manifestation of the fungal keratitis, and this is very important, that usually the symptoms start within 5 to 10 days from the history of trauma with organic or vegetative objects or the use of contact lenses. And usually there is some symptoms like foreign body sensation, gradual increase in the pain, and the diminution of vision. These are non-specific symptoms. However, the pain is gradually increasing and sometimes becomes very severe. Unless in immunocompromised people, you will find the pain is disproportionate with the corneal pathology. Now, the signs, regarding the signs, there are some specific signs which is to large extent suggestive of fungal keratitis, especially the feathery margin appearance. Now, this feathery appearance, unlike in this one, the lesion has a feathery margins. This is very highly suggestive of fungal keratitis. Also, you'll find the lesion is elevated from the surface of the cornea with a rough texture, and you will find that the cornea appears as if dry and loose of luster. This is also a feature of fungal keratitis. The presence of multiple satellite lesions, that you will find more than one infiltrate. Also, this is a feature of fungal keratitis. You will find sometimes pigmentation, especially in the dematicious fungi, and collar button, which is the immune ring. This is an immune ring. You will find sometimes the ring around the infiltrate, which is an immune ring. The hypopyon is pyramidal in shape and fixed, and usually not sterile because of the invasion of the organism inside the anterior chamber, and is not respecting the movement of the head position. And also sometimes you find lack of sensation from the cornea due to chronic ocular surface problems. Now, other non-specific, for example, conjunctival injections, you will find an epithelial defect, namely pseudodendrites. And as I explained before, that the true dendrites, you will find branching uprising defect in the epithelium with terminal expansion. However, in the pseudodendrites, you will not find the terminal expansion. This can be seen in fungal keratitis. So we will see in the next slides each type of the fungal keratitis, but this is general signs, namely the feathery appearance of the lesions on the cornea, and the satellite lesions are highly suggestive of fungal keratitis. Now, for the septated hyphae, as I mentioned before, we have the Fusarium and Aspergillus fumigatus. Now, Aspergillus is a little bit slowly progressive course, and slowly progressive that will not lead to a severe inflammations, unlike the Fusarium. Fusarium may lead to severe melting and perforation of the cornea and has a very malignant course. So Fusarium is very risky and can lead to destroy to the cornea within weeks. However, Aspergillus fumigatus usually a slowly progressive insidious course. The clinical features involves any parts of the cornea as a white, yellowish, grayish ulcer. As I said, there might be some pseudodendrites. Usually the lesion is elevated with growth and extension deeper to the layers of the stroma and even to the anterior chamber, with multiple satellite lesions and feathery margins. Now, feathery margins, this is very important. Now, if you see the pictures, as I said, that this is the typical picture of the feathery margin, irregular with small branching. So this picture is characteristic for fungal keratitis, and especially caused by hyphae. Similarly here, this is the feathery margin, it's scotted-like. Okay, this is the feathery margin. And this can be seen in many types of fungi, but can be seen mainly in the septated hyphae. Now, the other thing is the presence of endothelial plaques. This is large endothelial plaques, means that the organism has reached to the anterior chamber and it forms plaques over the endothelium. And also the hypopyon, you can see it is pyramidal in shape, and is not respecting the movement of the eye or the head. So this is called double-layered hypopyon, double-layered hypopyons. The other thing is the multiple infiltrate in the cornea. This is called as satellite lesions. You can see multiple infiltrates in the cornea here and there, and this is the feathery appearance. Now, the other type of the septated hyphae, which is causing mycotic keratitis, which is characterized by pigmentation known as the dematicious keratitis, caused by Cervularia species. It forms a corneal infiltrate with ulcer and with melanin secretions, and also characterized by the presence of immune ring around the lesions. This dematicious keratitis can infiltrate deeply and towards the periphery, and can cause severe hypopyon, iritis, and even endophthalmitis. So the characteristic feature is the presence of pigmentation, as you can see here. When you find a lesion with this pigmentations, this is very peculiar and specific to the dematious keratitis, and is, as you can see, associated with severe inflammation and hypopyon. Similarly here, the brownish pigmentation. So the pigmentation ranges from brown to black color. You can see the severe hypopyon, which is feature of this dematious keratitis. And as I said, the hypopyon here is not respecting the movement of the head of the patients. Now we come to the important aspect, that is the management of mycotic keratitis. In contrary to the management of bacterial keratitis, where we have said that we have two regimes, that's monotherapy for an ulcer less than 3 millimeter with superficial infiltration and no hypopyon. Here in the mycotic keratitis, the indication for monotherapy, when we have a superficial ulceration of less than 5 millimeter, less than 1/3 of the stroma is invaded, and there is traces or minimum hypopyon. Now, the drug of choice for monotherapy is natamycin, which belongs to the polyene group of drugs as antifungal. Use it half hourly for 24 hours, then hourly. And also as alternative to natamycin, if it is not available, we can use amphotericin topical preparation as 0.15% drops, which is mainly active against aspergillus and candida. It has no effect in fusarium. And also topical voriconazole, which is very effective against aspergillus and candida and has poor response against fusarium. So the drug of choice is natamycin. However, if natamycin is not available, we can use amphotericin or voriconazole. Now, I would like to remind you here that both natamycin and amphotericin B are both belong to the same group of drugs, that's polyenes, and the combination of these two drugs is not additive or will add more effect. So better not to combine natamycin with amphotericin. If we have to do combination therapy, I will explain later. We can use natamycin along with voriconazole, or we use amphotericin along with voriconazole. Of course, the adjuvant medications like cycloplegics, analgesia, and sometimes super added bacterial infection is there, so we can add antibiotic, and this is confirmed by the culture result. So we can add antibiotic if it is suspected. Now, the review of the case is very important every second or third day to see the improvement. And if there is improvement, we will continue with this monotherapy. And if there is no improvement, so we can go for the combination therapy. Now, I would like to remind here about the rule or the benefit of the scraping or the debridement of the corneal ulcer and fungal keratitis. It has an important role in debulking and decreasing the load of the fungus from the surface of the cornea, as well as it improves the penetration of the antifungal drugs to deeper to the stroma, because presence of intact epithelium and the presence of debris, this will limit the absorption and the penetration of the antifungal drugs inside the cornea. So the removal of the epithelium is very important at this stage to secure good concentration of the antifungal drugs within the stroma, especially if it is due to dematious fungi. The debulking should be done daily in each visit so that decrease the load of the fungus from the cornea. Now, if the previous regime failed, if you have a single-eyed patient with ulcer more than 5 millimeter with deep ulceration, endothelial implants due to the oxidation and due to the toxins from the hypopyon, if you have scleral involvement and there is no improvement from the monotherapy till 2 weeks, at that time the combination therapy is advised. The usual regime is the combination of natamycin with voriconazole or the amphotericin with voriconazole. The combination of amphotericin and natamycin is not advisable as they are not synergistic, and they belong to the same group, that is the polyene group. So the combination therapy is mainly we can add natamycin along with voriconazole. Now, as far as we are speaking about the drug management of the mycotic keratitis, we cannot speak or we don't mention about the MUT trial, that's the mycotic ulcer treatment trial 1 and 2 in the management of mycotic keratitis. Now, the MUT trial number 1 studied the topical natamycin versus the topical voriconazole treatment in the mycotic keratitis, which is a randomized trial comparing the natamycin topically along with voriconazole. And the result came that voriconazole should not be used as a monotherapy in filamentous keratitis, especially due to fusarium, because voriconazole has a good effect against aspergillus as well as the candida. And the topical natamycin treatment significantly better and gives better microbiological outcomes as compared to the voriconazole for filamentous fungus, and much improve the results, especially in the fusarium. So based on the recommendation from the MUT trial 1, the drug of choice is the natamycin, which has a large range of effect against filamentous keratitis, especially the fusarium. And as we said before, that the fusarium is very dangerous and can rapidly deteriorate the case. So as initial monotherapy, it is not advised to start with voriconazole, especially if the infection is due to the fusarium. This is the recommendation from the MUT 1. Now, as a recommendation from the MUT2, topical natamycin, they compare the two groups. They use the topical natamycin along with topical voriconazole, and the other group, they use the topical natamycin, topical voriconazole along with oral voriconazole. Now, the study similarly is a double-masked placebo-controlled trial in filamentous keratitis only. All the treatment group received topical natamycins and voriconazole, and another group received oral voriconazole for 100 milligram twice a daily, and then 200 milligram for 2 weeks, and then they see the response. The recommendation says that the addition of oral voriconazole did not decrease the rate of perforation or the rate of therapeutic keratoplasty. However, the fusarium keratitis may benefit from the addition of oral voriconazole to the topical natamycin. So if you have infection with fusarium, better to go with the combination therapy that's oral, not that's topical natamycin along with oral voriconazole. Now, the treatment group had 2 times more adverse reaction with as compared to the placebo. So the addition of oral voriconazole has no additive effect if it is just due to filamentous due to aspergillus. However, if it is due to fusarium, it has an additive effect to the topical natamycin. Another important aspect is how long should we continue the antifungal treatment. Now, there is no standard rules when to stop the antifungal treatments, because it is variable. So some say that after healing of the ulcer, you can stop the antifungal treatment. And there is a rule of thumb that you continue for another 2 weeks till complete epithelialization and healing of the ulcer. You should continue for at least 2 weeks. And even after you stopping the treatment, you should follow your patient for another 2 weeks to look for any evidence of recurrence. Here are certain important points that I would like to remind, that all antifungal drugs are fungistatic and not fungicidal. And this is add to the dilemma on the management of the fungal or mycotic keratitis, that there's no much advanced improvement in the antifungal medication. For example, the natamycin is used since 1960s, and still now, up till now, it is the drug of choice of mycotic keratitis. And the other challenging point, that the penetration to the cornea is limited for topical antifungal medication in the presence of intact epithelium. So as I said, that natamycin is the drug of choice because it has broad spectrum activity against filamentous keratitis, aspergillus and fusarium, and also against the candida, unlike other medications like the amphotericin B, which is primarily acting against candida and filamentous keratitis, except the fusarium. Similarly, the fluconazole. So the poor penetration of the drug inside the cornea is one of the challenging points that make the natamycin is not that much useful in deep keratitis or deep stromal keratitis. So addition of another medications like voriconazole is very important, or the use of intracameral injections or intrastromal injections of antifungal. Now, as I said before, that the combination for antifungal drugs, we should respect the category. The natamycin and amphotericin B should not be combined because they belong to the same category. That's the polyenes. If we want to do a combination, we use one of the polyenes, that's the natamycin or amphotericin B, along with the azole group, which is voriconazole. The other thing that the use of intracameral injections, especially of amphotericin B, is very useful in the presence of large exudates inside the anterior chamber and epithelial plaques. This helps in the debulking and sterilization of the anterior chamber. Also, the intrastromal injections of voriconazole in deep mycosis of the cornea is very effective, but you need to do frequent injections. Now, if you look in the animation or the videos that I showed here, this is a removal of large exudates from the anterior chamber in deep mycosis with endothelial plaques. As you can see here, this is very helpful in the management. And then intrastromal injections of voriconazole. You can see here intrastromal injections. You need to have multiple injections around the infiltrate and take care not to go to the central part, not to induce perforations. The problem that the duration of the voriconazole is short, so you need to do recurrent injections every alternate day for intrastromal voriconazole. And this mode of treatment only for deep mycosis and deep infections, and provided it not due to fusarium, because voriconazole is not effective against fusarium. Now, another aspect of the discussion is the role of systemic antifungal. Now, based in the MUT study number 2 that we said the use of oral voriconazole, they found no additive effect of the use of oral voriconazole along with topical medications, for different reasons. That the voriconazole is very expensive and also it has a hepatotoxic effect. However, the indication for the use of systemic oral antifungal has limited indication in single-eyed patients after failure of combination therapy, when there is a scleral involvement or deep anterior chamber involvement, or there is a threatened perforation. At these situations, we can add the oral antifungal drugs, namely the azole drops, that's the flucanazoles in Candida, ketoconazole in filamentous fungus, or itraconazole in filamentous fungus as well. Voriconazole is very expensive and it has no additive effect. So to summarize the treatment of fungal keratitis or mycotic keratitis, there is one famous protocol known as the TST protocol done by one of the Indian doctors. This stands for the topical, systemic, and targeted therapy. That when we use the topical or topical with systemic, or topical along with systemic and targeted therapy means the intrastromal injections. So it is said that the first line of treatment will be just topical natamycin 5% with or without addition of oral antifungal, as we said before, in the presence of severe ulceration, keeping in your mind that these antifungal, they are hepatotoxic, and voriconazole is also may cause hallucination, so it should be used with caution. Now, the second line of treatment, if there is no improvement, we can add another topical voriconazole, and if there is no improvement, the third line is to use a targeted therapy, that's the intrastromal injections or intracameral injections of voriconazole or amphotericin. And at the end, if there is no improvement and there is the risk of perforation, therapeutic keratoplasty will be the end result. So this is the diagram showing how to deal with the case. So you start with topical natamycin. If the response is good, you will continue. If the case is very severe, so you can use systemic antifungal. And if there is no response or poor response, you can add voriconazole and see the result. If it is good, so you will continue with these two combination therapy. If not good, within 7 to 10 days, you should go for the intrastromal injections or the targeted therapy of the intrastromal voriconazole or intracameral amphotericin. If all these fail, so the end result will be a therapeutic keratoplasty, or what's known as a hot keratoplasty, that it is done under emergency. So how we can prepare the intrastromal voriconazole? The dose for intrastromal voriconazole is 50 microgram per 0.5 ml. So if the vial containing 200 milligram, you add 19 or 20 cc. So you will have 200 milligram per 20 cc, that's 10 milligram per ml. Then you will add to the solution take 1 ml from this solution, add it to 20 ml. So you will have 0.5 milligram per ml or 50 microgram per 0.5 0.1 ml. So this is the dose for intrastromal injections of voriconazole. And in a previous video, I show how to do the intrastromal injections. Now we come to another alternative modality of managing infectious or microbial keratitis, which is known as the BACCXL. BACCXL stands for photoactivated chromophore for infectious keratitis. This is a novel technique that uses the cross-linking as a primary technique or alternative to antimicrobial treatment, or as adjuvant therapy in combination with antimicrobials. And here we are speaking mainly about the fungal and bacterial keratitis. In viral keratitis, it's contraindicated to use this type of treatment because there is a chance of recurrence of the virus with the CXL, as it has been reported by many studies. So we are speaking about fungal and bacterial keratitis. We are speaking about superficial infections. These superficial infections, there are many studies that CXL may be an alternative or adjuvant therapy in the management of microbial keratitis, especially in the presence of escalating and growing evidence of antimicrobial resistance. And the use of the CXL in the management might also decrease the need for hot keratoplasty or therapeutic keratoplasty, and also in the sterilization of the cornea before therapeutic keratoplasty. So that this is a new novel modality of treatment gaining more importance in the management of infectious or microbial keratitis, namely bacterial and fungal keratitis. Another alternative modality for managing the infective keratitis is by using the collagen cross-linking. Now, the collagen cross-linking use in infective keratitis has been placed for a large debate between doctors regarding the usefulness of this modality of treatment in managing infective keratitis, especially superficial keratitis, namely bacterial and fungal keratitis. It has no role and are actually contraindicated in presence of viral keratitis. And the debate was the people who are supporting the use of collagen cross-linking, that by collagen cross-linking we are strengthening the outer stroma by creating a chemical bonds between the lamellae of the stroma, and this will prevent the proteolytic enzymes and minimize the digestion and the risk of perforation of the cornea, either because of the release of mediators from the infective organism itself or from the immune host system itself. The other points that supporting this evidence that they look to the duration of the management of the infective keratitis, especially the fungal keratitis, which might reach up to 6 to 8 months. So the need for alternative way of accurately sterilizing the cornea from the pathogen is very important, and perhaps the use of ultraviolet and cross-linking might be an alternative method. Another thing that infectious keratitis is one of the leading causes of preventable blindness, and the need for an accurate and precise management of the case is very important. So cross-linking solve this dilemma when you are facing a case that you don't know whether it is a fungal or bacterial. So by the use of ultraviolet, which is effective against both fungal and bacterial, so you can solve the problem and manage whatever the causative organism regarding without the need for waiting for the pathology or the microbiology lab for the result. And also by this way we simplify the management so that even a general practitioner in the outpatient department, he can immediately start the cross-linking of a cornea in such cases without the need for an expertise and an expert doctor who will judge about the case. Once you are sure that this is a case of fungal or bacterial keratitis, so immediately you can start your cross-linking. And one of the drawbacks on the management of the infectious keratitis is the cost. The cost of the management is high because you will keep on watching your patients and visiting you for a long period, up to 6 to 8 months. And this, for some people or poor people, is not affordable. And this might be one of the burden for the patients and lead to the development of blindness. So all these factors support the people who are saying that we have to use the cross-linking and we have to make more research on the cross-linking as a treatment tools in the management of infectious or bacterial keratitis. Now, the other partner or the other party of the debate that against the use of cross-linking, saying that by cross-linking we are increasing the bonds and the tightness of the outer stroma, and this will reduce the permeability of the antifungal drug, which already under minimum concentration inside the cornea, and the bioavailability of the antifungal drugs will be threatened. So this will retard the effectiveness of the antifungal or antimicrobial drugs in the management of the pathogens. So they suggest not to use the cross-linking. So till now, there is no strong background clinical evidence regarding the usefulness. There are some studies supporting this, and some are still still running. We are waiting. A large randomized controlled trials is running in different parts of the world, multi-centers, regarding the usefulness of this type of modality, which is named as PAC-CXL. As you know, the PAC-CXL stands for the photoactivated chromophores for keratitis, and there are initial results supporting the usefulness of cross-linking in these cases, especially in superficial keratitis, either due to bacterial or due to fungal keratitis. Some studies shows that complete cure with complete shortage of time in the management of the case on just pure CXL treatment without any adjuvant therapy with antimicrobial or antibiotic treatment. So till now there is no strong evidence, but different randomized controlled trials, multicentric, are running, and we are awaiting the result for this modality of treatment regarding its usefulness in the management of infective keratitis. Now, the photoactivated chromophore for infectious keratitis, or the PAC-CXL, is one of the modalities for the management of infectious keratitis. As you know, the corneal cross-linking received the FDA approval as a minimally invasive intervention that utilizes the ultraviolet and the riboflavin. And the goal for the CXL is to increase the degree of cross-link between the lamellae of the outer stroma, and will provide a sufficient mechanical stability. So by utilizing the riboflavin along with the ultraviolet A, significantly increases the tensile strength and the biomechanical resistance to collagenases, either from the pathogen itself or from the host immune system itself. Apart from this, the cross-linking has an antimicrobial effect, and that's why it is used in the microbial keratitis by activating the photoactivated chromophores, which will be bound to the DNA of the organism itself and lead to retardation of the multiplication of the organism. Also, the ultraviolet A itself has an effect on the DNA of the organism, and also by the release of the reactive oxygen to the cells, so this also will lead to the damage of the pathogens. So there are various protocols for various organisms, and it is mainly used in superficial keratitis, either due to bacterial or fungal keratitis. Another advantage of the PAC-CXL that it reduces the toxicity of the cornea. So while we are attempting to do therapeutic penetrating keratoplasty, as you know, the recurrence rate of such hot keratoplasty is very high because of the infection might extend up to the limbus. So by sterilizing the cornea before doing penetrating keratoplasty, that's the therapeutic keratoplasty, using the CXL, this will reduce the toxicity and reduce the need for surgery sometimes, and also the chance of recurrence. So it has no role in deep ulcers, but mainly in superficial ulcers. So still, as I said, we are waiting different results for the role of the PAC-CXL in the infectious keratitis, although the initial results are promising. These are some of the studies that showing that PAC-CXL is effective in the management of microbial keratitis. The one which is done by Tawfiq et al. At 2020 and Torres et al. At 2020. They show that the use of PAC-CXL will reduce the treatment time and enhance the resolution of the ulcerations. And some also, they say that CXL alone is sufficient to eradicate or treat microbial ulcer if it is the size less than 4 millimeter. Frankly speaking, and really I should tell you that also there are some other studies showing that there is no improvement or there is no benefit of the use of the CXL in the management of microbial keratitis. And still the subject under a great debate, and still investigation is going on, and there is a big randomized controlled trial conducted multicentric to solve this issue and to answer all the questions and the query about the usefulness of the CXL using the photoactivated chromophores in the management of microbial keratitis. Some other people, they use the rose bengal as photoactivated chemicals, but it has shown only limited penetration in the cornea, so only superficial part of the cornea. That's why this type of modality is limited for superficial ulcerations with a small size, but for deep mycosis or deep corneal abscess, this is definitely not useful, and we need still to rely on our antibiotic with the different ways of administrations. Now I finished this part of lecture regarding the fungal keratitis, and the next lecture or the next session will be regarding viral keratitis. Herpes virus is a group of viruses that has a common feature, which is a double-stranded DNA genome surrounded by a lipid bilayer envelope. There are about 6 or 7 types of herpes virus that affects the human eye. Of course, the most common one is the herpes simplex type 1 and type 2. Other type is the varicella zoster virus, which is known as the chickenpox, and when reactivated is known as herpes zoster ophthalmicus. And the Epstein-Barr virus and the cytomegalovirus, and also the herpes virus associated with Kaposi sarcoma, which is known as the human herpes virus number 8. And another common feature for the all herpes virus establishes a latency in the natural host. For example, the herpes simplex virus type 1 and type 2 and varicella zoster, they usually becomes latent after the primary infection, commonly in the dorsal root ganglia, such as the trigeminal ganglia or the spinal ganglia. So that when reactivated, it will commonly affect the thoracic area in case of herpes zoster, and also in the trigeminal distribution, especially the ophthalmic division of the trigeminal nerve in case of herpes simplex. And also, for example, Epstein-Barr virus has a latency in B lymphocytes. So this is the common feature for herpes viruses, that they have a double-stranded DNA surrounded by an envelope, a lipid bilayer, and also they have the tendency for latency in the host, so that it has a future recurrence under particular situation, and it is closely related to the immune system of the host system. Now, herpes simplex, the importance of herpes simplex keratitis, that it is a leading cause of infectious cause of corneal blindness. The most common cause of corneal blindness, especially in developed countries, is due to herpes simplex. Perhaps in the developing countries, there are other common causes of corneal blindness. Most likely, the trauma is the most popular one, and also the other causes of infectious keratitis as a common cause, like bacterial and fungal keratitis. Now, these data from the developed countries, that new cases or the incidence of herpes simplex ranges from 5 to 15 cases per 100,000 populations, and the occurrence of ocular herpes simplex was seen in 32% during the first year after infection with herpes simplex keratitis. So the incidence of recurrence will be seen in 32% of the cases within the first year. So globally, there are around 1 million new cases and around 9 million recurrent episodes of ocular herpes simplex per year, and this is data based on the developed countries and not in the developing countries. The developing countries, still there is no accurate statistical data showing the exact prevalence and incidence of herpes simplex keratitis. Herpes simplex virus is a DNA virus, double-stranded DNA virus. It has two types, herpes simplex 1 and herpes simplex 2. Herpes simplex 1 usually present in the oropharynx and transmitted by the direct contact or by kissing, and herpes simplex 2 usually in the genital areas and is responsible for the congenital herpes that happens to the children during the birth, passing through the birth canal. So the most common cause of ocular infection is due to herpes simplex 1. Unfortunately, it is more than 90% is unilateral corneal infections. Rarely it becomes bilateral in around 11% of the cases, and sometimes is more prevalent in adults and immunocompromised people. So the infection is transmitted by direct contact, by inoculation through the mucosa and the surface and the skin, or through the passing through the birth canal, especially in children. After exposure to the herpes simplex virus, the virus will become dormant in the trigeminal ganglia and can stay there for a long period. And for unknown reasons, it gets reactivated based on certain stimuli like the ultraviolet, stress, fever, menstrual cycle, steroids, immune suppressions. And upon reactivation, it retrogradely moves through the nerves and through the trigeminal nerve and reach to the eye, to the cornea by passing through the nerves that's supplying the cornea. This is how the herpes simplex cycle, which started from the first exposure, primary exposure, up to the secondary reactivation. As I said before, that primary herpes, after the first exposure of the patient with the herpes simplex, this is called primary herpes. Now the virus will become dormant and travel through the nerves of the eye and becomes dormant in the trigeminal ganglia for a long period, and for unknown reasons will lead to a reactivation of this virus, and it will be moved by retrograde movement through the nerves to reach to the eye. Now, these factors that are responsible for reactivation, like the presence of sunlight and sometimes trauma like surgery, contact lens wears, heat or abnormal temperature, hormonal changes, emotional stress, or glaucoma medication, especially prostaglandin analogs, they are claimed, but there is no strong evidence. And in immunocompromised people, so the virus will replicate through the trigeminal nerve and retrogradely will reach to the eye. Now, if we look to the epidemiology of herpetic keratitis, that's herpes simplex keratitis, fortunately, 90% of the cases are unilateral. Rarely you will find bilateral herpetic keratitis. And however, the recurrence rate is high, so that within 10 years, up to 67% the recurrence within 10 years. And this is unlike the herpes zoster, in which the recurrence rate is very low in herpes zoster. Now, the pathogenesis of the herpetic keratitis or herpes simplex keratitis lies by three mechanisms: by active infection itself, so that you will find the virus or the virus particle within the inflammations, or by inflammation from the active infection, the inflammation induced by the host itself. And this might cause inflammation even in the adjacent structure, so that you find the infection in the epithelium, but the inflammation in the stroma. The third way is by immune mechanism mediated, even if the infection is not there and the virus is not there, but there is an immune mechanism due to delayed hypersensitivity reaction due to the retained antigen particles of the virus. So this induces an immunological reaction. So you have three ways of inducing herpetic keratitis, either by active invasion of the virus itself, or by the inflammation induced by this invasion, or by the delayed immune response. And the active replication of the virus inside the epithelium or inside the stroma itself can be either due to by direct inoculation of the virus, or by reactivation of the virus from the virally infected cells, or death of these cells, so that there will be a release of the virus particles. So this is very important to understand the mechanism, and so that you know what type of drugs you are going to use. And it is very important for you to know whether you are dealing with an active infection or reactivations or an immunological reaction, because this will determine the type of drugs you are going to use. Either you are going to use an antiviral, or you are going to use steroids, or a combination of both. Now, the herpetic eye disease and the manifestation of herpes infection in the eye can be in the form of a primary herpes or secondary or reactivation of the herpes. Now, the primary herpes represent the first exposure and commonly in young children, usually manifest as ocular infections or even skin infections. The ocular infections in the form of conjunctivitis, acute follicular conjunctivitis, and may be passed unnoticed. And sometimes, rarely, it can involve even the cornea in the form of fine epithelial keratitis or even dendritic ulcer. Although this is the corneal manifestation of primary herpes are rare. Now, this is the herpes labialis, and this is the skin manifestations, similarly here. So it can be in the form of eye or skin manifestations. Now, the recurrent herpes or the secondary herpes has a wide spectrum of presentations to the epithelial infections in the form of dendritic, punctate keratitis, geographical ulcers, or stromal infection in the form of disciform keratitis or necrotizing keratitis or endotheliitis, also metaherpetic or trophic keratitis. Now we will discuss every one of these in details. Now, as far as the important points regarding the recurrence in herpes simplex keratitis, that if you have an epithelial or initial episode of epithelial keratitis, the chance of having the same keratitis in the future is 15%. However, if you have a non-epithelial keratitis, the chance of having epithelial keratitis is 12%, which is nearly the same. However, if you looked for the stromal keratitis, if you have initial episode of stromal keratitis, the chance of having another attack of stromal keratitis is 28%. However, if you have an initial episode of non-stromal keratitis, the incidence will drop down to 3% only to have a stromal keratitis. And these facts are very important when you are planning or to contemplate a prevention program, so that to know that if you have an initial attack of non-stromal keratitis, the chance of having stromal keratitis is very low. However, the chance for having epithelial keratitis will be high. Another thing regarding the recurrence is the number of previous episodes. Now, if you have increased number of previous episodes of that attacks, so the risk of future attacks will be also very high. And also the interval between the attacks. If you have a short interval between the attacks, the same thing will be for the future attacks. Also, they will have a short interval between episodes. Now, if we have a quick look to the different terminology used in the herpetic eye disease, there was different levels of classifications, and terminology should be understood because these terms can be used interchangeably. So there was initial historical or descriptive classification based on the shape. So the dendritic ulcer or geographical ulcer, interstitial, nummular, necrotizing, disciform. And there's another classification based on the location of the structure involved. As we said, that any structure of the cornea can be involved. So it might be an epithelial keratitis or stromal keratitis with ulcer or without ulcer, or endotheliitis or trabeculitis. So this classification based on the location, and this based on the description. Another important thing regarding the herpes simplex keratitis, that herpes simplex can involve all layers of the cornea, from the epithelium in the form of dendritic or geographical ulcers, trauma in the form of necrotizing keratitis or without ulcerations, and the endothelium, and as a disciform keratitis or as a trabeculitis. So all layers can be involved. However, the exact pathogenesis differs from layer to layer. For example, the epithelium, due to active viral replication or multiplication, so this is very important. However, in stromal involvement without necrosis, that's non-necrotizing and without ulceration, it is purely due to immunological reaction. And if there is stromal involvement with necrotizing keratitis due to ulcerations, so this is due to a combination of both immune mechanism as well as live virus multiplications. Similarly, in endothelial involvement, it can be pure in the immunological mechanism, or it can be a combination of both immunological mechanism and active viral replication. And this is very important to strategize your management plan and know when to use steroids and not to use steroids, and also when to use topical antiviral and not to use them. Now, as far as the susceptibility of the host system to the HSV keratitis, we have general susceptibility factors and the local susceptibility factors. Now, the general susceptibility mainly concentrated on the abnormal immune system or altered immune system. Abnormal immune system means decreased in the cell-mediated immunity as seen in organ transplantation patients with judicious use of immunosuppressant like steroids and other medications. Also, people with diabetes mellitus, and also it is found that with active measles infections, the cell-mediated immunity is altered, and those patients are at higher risk of having HSV keratitis. As far as HIV infections, the different studies doesn't show that people with HIV has an increased incidence of newly HSV keratitis. However, the recurrence of HSV keratitis is more in HIV patients as compared to non-HIV people. Another category of people who has altered or they have altered immune system, which is the people with children or in patients with atopy. Now, in children, we cannot say that they have decreased immunity, but we have an altered immune system, differs than the adults, so they have more likely bilateral cases as compared to adults. So the bilateral HSV keratitis is more in children as compared to other adults. Also, the combination of both epithelial and stromal keratitis is more common in children as compared to adults. Also, the high recurrence rate, especially in the first year, because usually commonly misdiagnosed and patient will not receive the antiviral treatment. So the recurrence rate is very high within the first 1 year. And usually the inflammation is severe and robust and end up with severe scarring and inflammation. So special care should be taken in a patients with in children with HSV keratitis. Another category is the people with atopy. Now, people with atopy also, they have an altered immune system with different IgE level in the serum, as well as they have different immune systems mediators, and also the predominance of eosinophilia. So they have a higher incidence of HSV keratitis as compared to other people. Atopy is defined people with family history of high fever or allergic rhinitis. So they have 2 to 4-fold increased risk of HSV keratitis with ocular involvement. And also, it is found that they have more severe form of keratitis as compared to non-atopic people, and more likely have a bilateral disease, also like in children. And also, they have less response to the antiviral medications. They found that atopic people, they have less response to the antiviral, either topical or systemic antiviral medication. So this is another category. They have altered immune system. They have a general susceptibility to HSV keratitis, like in children and in atopic people. Now, after finishing the general susceptibility factors of the host system, now we come to the local factor. There are certain local factors increase the susceptibility for HSV keratitis. Among these is the medications, topical medication, the use of prostaglandin analogs, like in anti-glaucoma treatment. They found that they have increased incidence of recurrence of HSV keratitis. Also, the topical use of steroids, and surprisingly also the angiogenesis inhibitors like Avastin, the intravitreal injections of ranibizumab. So these medication, they found that they has increased incidence of recurrence, although sometimes we use this medication also in the treatment of neovascularization of the cornea in patients with HSV keratitis. Another thing is the some local trauma or some local inflammations. They increase the risk for the recurrence of the herpes simplex keratitis, like the use of contact lens wearers, also in laser surgery like LASIK. Mainly LASIK increase the risk of epithelial keratitis, and the BRK and BTK also increase the risk of stromal keratitis. Also, it has been reported that after YAG laser iridotomy or capsulotomy, the incidence of recurrence of HSV keratitis, and also the use of argon laser trabeculoplasty. and surgery in the form of cataract surgery and penetrating or lamellar keratoplasty. As I said, they increase the chance of recurrence, may be related to the stress system and stress to the immune system, and for maybe unknown reasons, they found that they have increased incidence of recurrence of HSV keratitis. Now, in our lecture, we will follow this classification as epithelial involvement, which could be infective or non-infective. The infective epithelial involvement is due to corneal vesicles or dendritic ulcers, geographical ulcers, marginal ulcers, and usually they have mild symptoms of lacrimation, photophobia, irritation, and pain. Now, the epithelial non-infective involvement is neurotrophic keratitis, is epithelial involvement, but it is not due to active replication of the virus itself. The other stromal involvement can be also immunological, where there is no active replication, or it could be necrotizing due to active multiplication and replication of the virus itself, or endotheliitis. This is the general scheme that we will follow in this lecture. Now we come to the clinical presentation of herpes simplex keratitis. You can see that herpes simplex keratitis can involve any layer of the cornea, starting from the epithelium to the stroma and then to the endothelium and even the nerves and finally to the neurotrophic keratitis. So we'll start with the epithelial keratitis, and this is the most common presentation of herpes simplex keratitis, can take the form of dendritic ulcer or geographical ulcer. And even if untreated, it will heal within 17 days for a primary infection, or if there is recurrence, it can reach up to 28 days. And usually due to active replication of the virus itself within the cells of the corneal epithelium. And it will be preceded by mild symptoms of photophobia and pain and watery discharge. And clinically, when you examine the case, you will find at very early stages mild punctate epithelial erosions, tiny, with the small vesicles that will erupt within the next 24 hours and convert to a dendritic ulcers. And these dendritic ulcers are true ulcers in the sense that they are branching, are porizing with terminal expansions. And these ulcers, they can invade the basement membrane and they can do significant scarring. Now, in comparison to the pseudodendrites that can be seen in herpes zoster, that it will not invade the basement membrane and it will cause minimal scarring as compared to the herpes simplex dendritic ulcerations. Now, the second type of the epithelial herpes simplex keratitis is the geographical ulcer. Now, this geographical ulcer, the name describes a large defect in the epithelium, and around 22% of the epithelial keratitis can convert or change to geographical ulcer, in which it would lead to more symptoms and more healing time. And it has been incriminated that the use of steroids for a dendritic ulcer will lead to the development of geographical ulcer. Other name of the geographical ulcer, also known as amoeboid ulcer, because it looks like an amoeboid. So you can see here in this picture, there is large dendritic ulcers, which is named as geographical ulcer. And you can see the defect in the epithelium is stained with fluorescein. However, it can be stained with rose bengal, especially the edge of the ulcer. The edge of the ulcer will be swollen and contains the virus, actively replicating virus, so it is stained with rose bengal. As you can see here, this is the amoeboid ulcer because it is large, and the same is here, is stained with the fluorescein. Now the third type of the epithelial herpetic simplex keratitis is the marginal ulcer. Now the marginal ulcer reflects an active viral disease, and there is active replication of the virus, and it is a rare but sometimes confused with the staphylococcal keratitis. As you know, one of the causes of marginal keratitis is caused by staphylococcal keratitis, which is an immunological reaction due to hypersensitivity to the endotoxins and exotoxins. However, in the herpetic marginal keratitis, due to active invasion of the virus itself, and if not treated, it will progress. Usually, it will progress centrally. Another feature of this marginal keratitis, to differentiate it from herpetic simplex, from staphylococcus marginal keratitis, is that there is no lucid interval. The lucid interval is an healthy area at the limbus between the inflammation and the infiltration, and the limbus. This is seen in the Staphylococcus marginal keratitis. However, in herpetic marginal ulcer, there is no lucid interval, so you can see the inflammation immediately at the limbus and will extend centrally. As it left without treatment, it will extend centrally. So there are certain differentiation between the staphylococcal marginal keratitis and the herpetic marginal keratitis, that in the herpes simplex marginal keratitis, it is an infective, but in the staphylococcus is immunological reaction due to hypersensitivity to the exotoxins. Now, the epithelial defect is always present. It means that when you apply fluorescein, you will find staining and usually progress centrally. And there is no lucid interval, as I said before. There is no lucid interval, and sometimes associated with new vascularization. This is very important to differentiate it from staphylococcus. And not associated with the blepharitis, is not necessarily, and it can be present at any meridian. However, in the staphylococcus variety of marginal keratitis, usually progress circumferentially, so it will go circumferentially and with minimal limbal injections, and usually there is a lucid interval. This is very important, and new vascularization is absent and usually associated with the blepharitis. And commonly in this location at 2 o'clock, 4 o'clock, 8 o'clock, 10 o'clock, as far as the staphylococcus marginal keratitis. This is some of the differential points. The main thing that in the herpetic marginal ulcer, there is no lucid interval, there is no vascularization, and there is no blepharitis. Now the third type of the epithelial herpetic simplex keratitis is the marginal ulcer. Now, the marginal ulcer reflects an active viral disease, and there is active replication of the virus, and it is a rare but sometimes confused with the staphylococcal keratitis. As you know, one of the causes of marginal keratitis is caused by staphylococcal keratitis, which is an immunological reaction due to hypersensitivity to the endotoxins and exotoxins. However, in the herpetic marginal keratitis, due to active invasion of the virus itself, and if not treated, it will progress. Usually, it will progress centrally. Another feature of this marginal keratitis, to differentiate it from herpetic simplex, from staphylococcus marginal keratitis, is that there is no lucid interval. The lucid interval is an healthy area at the limbus between the inflammation and the infiltration and the limbus. This is seen in the staphylococcus marginal keratitis. However, in herpetic marginal ulcer, there is no lucid interval, so you can see the inflammation immediately at the limbus and will extend centrally. As it left without treatment, it will extend centrally. So there are certain differentiation between the staphylococcal marginal keratitis and the herpetic marginal keratitis, that in the herpes simplex marginal keratitis, it is an infective, but in the staphylococcus is immunological reaction due to hypersensitivity to the exotoxins. Now, the epithelial defect is always present. It means that when you apply fluorescein, you will find staining and usually progress centrally, and there is no lucid interval, as I said before. There is no lucid interval, and sometimes associated with new vascularization. This is very important to differentiate it from staphylococcus. And not associated with the blepharitis, is not necessarily, and it can be present at any meridian. However, in the staphylococcus variety of marginal keratitis, usually progress circumferentially, so it will go circumferentially and with minimal limbal injections, and usually there is a lucid interval. This is very important, and new vascularization is absent and usually associated with the blepharitis. And commonly in this location at 2 o'clock, 4 o'clock, 8 o'clock, 10 o'clock, as far as the staphylococcus marginal keratitis. This is some of the differential points. The main thing that in the herpetic marginal ulcer, there is no lucid interval, there is no vascularization, and there is no blepharitis. Now we come to the second type of herpetic eye disease, which is after the epithelial involvement, we can have stromal involvement. This is more serious and a little bit less common, as only 20% of the herpetic eye disease can be presented as a stromal keratitis. And the reason that stroma always involved either secondary to the epithelial infection, so there will be secondary reaction in the stroma, or as a direct invasion of the virus itself, which is a microbial keratitis, lead to active multiplication of the virus itself, or secondary to reactivation or from neurotrophic keratitis. So stromal keratitis, as I will explain in the next slides, can be of two varieties, either due to immunological reaction or due to active inflammation itself from the direct invasion of the virus itself. Stromal keratitis is a form of microbial keratitis. It is more serious than bacterial keratitis because can lead to significant melting and thinning and even perforation of the cornea. Now, the first type of the stromal keratitis is the one which is due to active invasion and multiplication of the virus itself, which is known as necrotizing stromal keratitis. Although it is rare, but it is very serious and can lead to a disastrous outcome in the form of melting, thinning, and even perforation. And usually the inflammation is due to active multiplication of the virus itself and due to the inflammation induced by the host immune system itself. As you can see here in this picture, severe congestion with nasty appearance of the cornea and severe infiltration and thinning and even impending perforation here. So this type of inflammation is due to active viral invasion and multiplication. So urgent treatment should be taken, otherwise disastrous outcome will be there. So the necrotizing stromal keratitis can be due to necrosis, can cause necrosis of the stroma and even ulceration of the overlying epithelium. This is very important to differentiate it from the non-necrotizing type, which is due to the immunological reaction. You will find an ulceration over the surface of the cornea. And as I said, the dense infiltration is partly due to the active replication of the virus itself and partly due to the host immune system that lead to destruction of the stroma and thinning and end up with perforation. The second type of the stromal keratitis is the one which is due to immunological reaction, which is called interstitial keratitis or immune-induced stromal keratitis. This type of keratitis is not due to active infiltration or multiplication of the virus itself. It is some sort of delayed hypersensitivity reaction due to reactivation of the keratitis and characterized by special features that differentiate it from the necrotizing one by the absence of epithelial defect. Usually the epithelium is intact, and also the presence of new vascularization within the stroma of the cornea. The infiltrate will be as a patchy, punctate, or diffuse, and characterized also by the presence of what's known as Wesley ring. This is the Wesley ring due to immunological reaction, and this ring is because of the presence of the new vascularization. This will bring the immunological reaction, so this try to limit the spread of the inflammation from the stroma. So this is the main features of the immunological type of stromal keratitis that differentiated from the necrotizing one. Now, if we summarize the finding, so you will have patchy or diffuse infiltration. Sometimes you will find mild anterior chamber reactions, and this is the typical Wesley ring. And in some cases, due to the long-standing and also the presence of new vascularization, you will find what's known as the lipid keratopathy. That's you'll find yellowish deposits in the cornea, which is due to lipid keratopathy and also the new vascularization within the cornea. Now we come to the third type of herpes simplex keratitis, that is the endotheliitis. Now the endotheliitis, as I said before, that any structure of the cornea can be involved by herpes simplex. So the endothelium is part of the cornea and it can be involved and presented as endotheliitis. Now the endotheliitis is not a true infection or invasion by the organism itself. It is an immunological reaction due to inflammation of the adjacent structures. Either inflammation of the stroma can lead to endotheliitis, or if there is inflammation in the anterior chamber with uveitis, this also can lead to endotheliitis. The most common form of endotheliitis is disciform keratitis. However, we have the another varieties, which is the diffuse form or the linear form. I will speak about them later. So the endotheliitis characterized by presence of patch of stromal haze, and you will find fine KBs, and also you will find corneal edema over the disc of the keratitis. Now, the presence of KBs and the iridocyclitis raise the suspicion of the presence of trabeculitis, and most likely the IUP will be elevated. So this is very important that to check the IUP in such cases, because involvement of the trabeculum, this will lead to elevation of the high intraocular pressure. Now, the other types or the classification of endotheliitis, as I said, the most common one is the disciform keratitis. This is the simplest one and easy to be treated just by topical steroids. Usually, they have a disc-like shape, haziness in the stroma with super added corneal edema, and you will find fine KBs on the back surface of the endothelium. Now, the other type is, which is the diffuse type. This is more universal. You will find diffuse edema all over the cornea with diffuse haziness in the stroma and also the KBs, and it need more than topical steroids, need even systemic steroids. The most dangerous one is the linear one, which is radiating from the limbus and having a circumferential course. This will eventually lead to corneal decompensation and also a penetrating keratoplasty. Although the success rate is limited, in herpes simplex keratitis, it needs special management. But these are very rare. The most common one is the disciform keratitis with a good prognosis. So this is different types of the disciform keratitis due to involvement of the endothelium, endotheliitis. You can see here, nearly half of the cornea is edematous and hazy. And similarly here, you'll find microcystic edema, mild corneal edema involving the central part. Usually there is no much staining of the cornea unless associated with epithelial erosions. Now this is the other type, which has peripheral stromal edema all over the stroma and the periphery, and epithelial edema, and this will eventually lead to the corneal decompensation. So this is the different varieties of endotheliitis. As far as the management of endotheliitis, if it is just disciform endotheliitis, topical steroids may be enough to resolve the problem. And if it is due to linear endotheliitis or diffuse endotheliitis, it requires a topical steroids along with systemic steroids, as well as systemic antiviral as a prophylactic dose, at least 400 milligram 5 times a day for 2 weeks, and should be continued for at least between 6 to 12 months. Otherwise, if it is just disciform endotheliitis, just topical steroids is enough to clear the case. So the linear endotheliitis and diffuse endotheliitis have poor prognosis as compared to disciform keratitis. The fourth entity of herpes simplex keratitis is the neurotrophic keratitis, which is an epithelial defect belonging to the epithelial damage that happens during herpes simplex infection, and also known as metaherpetic keratitis because it happens after long-standing recurrent herpetic infection. So the neurotrophic keratitis has a special feature that usually it is large in shape and oblong in shape, with rounded and elevated edges. The margins of the ulcer, it will be elevated. And the stroma usually clean with the grayish white opacification unless super added with bacterial infections. And the thickening of the borders of the this trophic ulcer or metaherpetic ulcer can be seen clearly with the rose bengal. You will find the elevated edges of the ulcer. And this neurotrophic keratitis is exactly like the diabetic ulcers or the diabetic foot ulcer in diabetic people because of the loss of the innervations. So the also the corneal epithelium, one of the important trigger for multiplication and integrity of the corneal epithelium is the presence of the intact innervations. So due to recurrent herpetic keratitis, each time there will be damage to the nerve ending and end up with decreased sensation, profound decrease in the sensation of the cornea, and this will disturb the integrity of the epithelium and the ability of the epithelium to multiply and heal. So the complication of this keratitis is, if not managed properly, will lead to stromal scarring with new vascularization. This is a very important sign. When you find new vascularization with ulcer, you should think of this. And also necrosis and melting and even perforation of the cornea. And sometimes secondary bacterial infection. Now, the common causes is mainly is due to decreased or impaired innervation of the cornea. However, chronic use of topical medication, especially antiviral, as you know, the antiviral has toxicity to the epithelium. So, chronic use of topical antiviral may contribute to the occurrence of the neurotrophic keratitis, and also body medications that use multiple drops, including antiviral, antibiotic, and even other drops that contains the preservatives. This lead to what's known as keratitis medicamentosa, and this is part of the problem, lead to toxicity of the epithelium and impair the healing of the epithelium. The other thing is the decrease in the tear secretion, which is also related to the innervations. You know, the tear production mechanism is related to the nerve ending. When there is decrease in the nerve ending, so the reflex secretions of the tears will be impaired, and as a result, this will make the condition more worse. So for the metaherpetic keratitis or neurotrophic keratitis, you can see this is different varieties. You can see the grayish-white appearance of the ulcer with elevated margins. As I said, it can be seen clearly with rose Bengal. And if there is super added bacterial infection, there will be dirty base of the ulcer. And you can see clearly here the new vascularizations, indicate chronicity, and in the presence of ulcerations. And usually the patient has no pain. The surprising thing that you will find a large ulcer in the cornea, but the patient is not complaining of any pain. This is to differentiate it from an important ulcer, which is the exposure keratitis. People with facial nerve palsy and exposure keratitis, you will find also they have large ulceration, especially in the lower 1/3 of the cornea, but they will have profound pain. However, in these people, you will find large ulcer, but the patient is not complaining of pain. Now, the other thing is melting and collapse of the stroma, and this will lead to necrosis and even perforation. And this can be documented clearly by the OCT. When you do OCT for these people, you will find a facet or defect or depression in the cornea in this area, which indicate melting and herald for perforations. So the metaherpetic keratitis, the first thing to the management or the treatment is to stop all antiviral, because there is no active viral replication. So you have to stop the antivirals, and to avoid the toxic effect of these topical drops, use frequent preservative-free lubricant. This is very important. Preservative-free should be used, and rich in hydroxypropyl methylcellulose or sodium hyaluronate, and broad-spectrum antibiotic if you suspect secondary bacterial infections. Debridement is very important for the thickened edges, and sometimes mild steroids if you find significant haze in the stroma. Temporary tarsorrhaphy and amniotic membrane graft is the end if there is no improvement, and also bandage contact lens. Now it's the time to speak about the different medications available for the management of herpes simplex keratitis. But before we dive deeply in this respect and to know the different studies and the different regimes used in the management of herpes simplex keratitis and also the concurrent use of steroids, I would like just to give a general overview for the management to be easily to be understood by the doctors. Is that we currently have 11 antiviral drugs to be proven to be efficacy and effective against the herpes simplex keratitis. Out of them, nearly 5 2 topical and 3 systemic medications are proved and to be used. Topical like trifluridine and ganciclovir, and the 3 systemic is acyclovir, valciclovir, and famciclovir. And the regime usually used, we have the therapeutic low dose of antiviral medications, and we have therapeutic high dose, and then we have the prophylactic dose. So we have therapeutic low dose and therapeutic high dose and prophylactic high dose. Usually the therapeutic low dose used for epithelial keratitis, especially dendritic keratitis, and the therapeutic high dose used for geographical ulcers, that's an epithelial involvement with active virus replication but with large virus load. Also, this therapeutic high dose is used for herpes zoster as well. And the prophylactic dose that we will speak about it. So the therapeutic low dose, which is mainly or commonly is the use of acyclovir 400 milligram 3 to 5 times a day, or we use the equivalent dose of valciclovir 500 milligram twice a day for 7 to 10 days, or the famciclovir, which is 250 milligram twice a day for 7 to 10 days. So this is the therapeutic low dose. And as I said, that the therapeutic low dose is mainly used for epithelial keratitis, namely the dendritic ulcer, in which there is active virus replications and there is low virus load. Now, the other therapeutic high dose, which is using mainly the acyclovir 800 milligram 5 times a day, or the equivalent dose of valcyclovir 1 gram 3 times a day for 2 weeks to 3 weeks, or the famciclovir 500 milligram twice a daily for 2 to 3 weeks, and should not be used more than 3 weeks for the epithelial toxicity. And as I said, this is mainly kept for epithelial keratitis with high virus load, like geographical ulcers, or also it can be used when there is herpes zoster keratitis. So this is the main two regimes that is used in the management of herpes simplex keratitis for dendritic ulcers and for geographical ulcers. Now, in the next slides, we'll speak about the prophylactic dose that is used concurrently along with steroids for stromal non-necrotizing keratitis. Now, as far as the stromal keratitis, as we have said before, if there is a stromal keratitis without necrotization, without ulceration, so this is mainly due to immune mechanism. So in this scenario, we need to use the therapeutic dose of corticosteroids plus the prophylactic dose of oral antiviral. And by therapeutic dose of steroids, we mean prednisolone 1% 6 to 8 times daily and tapered over greater than 2 weeks. Plus, we use the prophylactic dose or the prophylactic dose of oral antiviral, that's the acyclovir 400 milligram twice daily, or the valcyclovir 500 milligram once daily, or the famciclovir 250 milligram twice daily. This is in case of stromal keratitis without necrotizations. Now, in case of presence of stromal keratitis with necrotization, that is necrotizing stromal keratitis, as I said before, that this is a combination of active live virus multiplication along with an immune-mediated mechanism. So in this situation, we need to limit the dose of the topical steroids to a minimum dose, and also we use the therapeutic dose of oral antiviral. So the frequency of the prednisolone, instead of 6 to 8 times, will be reduced to twice daily only, because there is active virus replication. However, we need to use the therapeutic large dose of oral antiviral, that is the acyclovir 800 milligrams, or the equivalent amount of other antivirals. Now, in case of the presence of endothelial involvement, that's endothelial keratitis, as we said before, that this is mainly an immune mechanism, but sometimes with mild live viral replication as well. So since it is an immune mechanism, so we need to use the therapeutic dose of topical steroids, that is the 1% prednisolone 6 to 8 times daily. And then we use along with it the therapeutic low dose of oral antiviral in the form of 400 acyclovir or 500 valcyclovir or 250 famciclovir. And in all these situations, the tapering of steroids will be gradually over a long period, at least 10 weeks. And we continue the oral acyclovir along till we stop the steroids. Then we can shift to the prophylactic dose of oral acyclovir. Now we come to an important question, which is the role of steroids in herpes simplex keratitis. And to sum up what we have said before and explain the relation between the steroids and the antiviral drugs, and when to use the therapeutic doses or the high doses of oral antiviral as well as steroids. As you know, that topical steroids has no role in epithelial keratitis, either dendritic or geographical. There is no role of topical steroids in these cases. Inversely, if you use steroids, you will worsen the situation because you will increase the active replication of the virus. So there is no role of steroids in epithelial keratitis, and we need to adjust and modify the dose of oral antiviral. In dendritic ulcer, we use a therapeutic low dose, and in the presence of geographical ulcer, we will use the therapeutic high dose. That's the 800 milligram, 3 to 5 times daily for 7 to 10 days. So this is as far as epithelial keratitis. Now, in stromal keratitis, we have two varieties. If you have stromal keratitis with necrotization or ulceration of the epithelium, in these situations, we need to use steroids, a combination of steroids and oral antiviral. However, since there is an ulceration and active viral replication, so we need to use the low dose of or low frequency of the steroids that we use 1% prednisolone twice a daily, and we use it for a long time and with a gradual tapering reaching up to 10 weeks. And we use the high dose, therapeutic high dose of oral antiviral, that's 800 milligram, use it for 3 to 5 times daily for at least 7 to 10 days. And you continue this high dose and monitor the response, and then you can shift to the therapeutic low dose, that's 400 milligram, 2 to 4 times daily for a long period till you stop the steroids and till you see improvement in the case. Now, in the presence of stromal keratitis without necrotization, so at that time we can use high frequency of steroids. That's 1% prednisolone. We can use it 6 to 8 times per day, and can we use it up to 10 weeks with a gradual tapering. And we use the low therapeutic dose of oral antiviral, that's the 400 milligram, 2 to 4 times daily for 7 to 10 days, and then continue till you stop the steroids. Now, there is a definite rule for topical steroids in the presence of endotheliitis or disciform keratitis, and it should be combined with oral antiviral drugs, because in the presence of endothelial keratitis, there is both there is an immunological response as well as active viral replication. So this is the relationship between the use of steroids and the oral antiviral drugs. The main thing that there is no role of steroids in epithelial keratitis. However, the role of steroids only in stromal and in endothelial keratitis. And as you know, that the advantages of steroids, that it will fasten the healing process and reduce the corneal scarring and the neovascularization, and it reduces the chance of having posterior synechia and the chance of secondary glaucoma. And we should keep watching in steroids because they might increase the risk of viral invasion and stromal necrosis due to secondary bacterial infection, and also secondary or cataract-induced steroid-induced cataract or steroid-induced glaucoma. And sometimes in very severe immunological response in the stroma or disciform keratitis, we might also need to use an oral steroid, especially in the presence of severe iridocyclitis or linear endotheliitis. So this is a sum up for all what we have said before and the interplay between the steroids and oral antiviral drugs. Here I would like to mention some of the available topical antiviral drugs. As far as the treatment, I will speak in details about the herpetic eye disease study in the next slides. Just I would like to mention a few words about the topical antiviral drugs available. Now, the famous topical drop is the trifluridine, which is also used in the herpetic eye disease study and is available in the United States because it is FDA approved. Now, the disadvantage that it has an epithelial toxicity, significant epithelial toxicity. The other new drug is the ganciclovir, is available in a gel form, and also it has FDA approval and has less epithelial toxicity. Now, the most famous one is the aciclovir, which is present as an ointment of 3%, but it has no FDA approval, so it is not available in the United States, and it is accepted by most of the doctors. They are using it since long time. Now we come to the oral antiviral agents. The most common and the most famous one is the aciclovir. Now this aciclovir is the most famous oral antiviral. It hasn't got FDA approval and it's not available in the United States. And it is the one which is used in the herpetic eye disease study. And it has a very poor bioavailability. Only 10 to 20% is absorbed through the gut. But it is very safe for the kidneys. That's why it is good in people with renal impairment, unless the glomerular filtration rate drops below than 20 ml per minute. So at that time, you should take care about this drug. The acyclovir works by inhibiting the virus DNA, by inhibiting the DNA polymerase, so it is virucidal. It causes damage to the DNA of the organism, so lead to its death. And as I said, it is one of the mainstay of systemic treatment for herpetic simplex keratitis. The other common and the other famous one is which is recently discovered, is the ganciclovir, which is also used as oral. The dose of around 400 milligram 5 times a day. Now the acyclovir, the therapeutic dose is 800 milligram 5 times a day. However, the prophylactic dose is 400 milligram. Now, the ganciclovir has a very good concentration inside the aqueous and inside the cornea, and it's significantly tolerated well by the patients and use it as ophthalmic gel. Now, there is another commonly drugs used, new drugs also used, which is the valciclovir and the famciclovir. The valciclovir is FDA approved, is at 1995, and the famciclovir is at 2006, and they have very good bioavailability, up to 50% use it, and the dose also is good. You can use it at 1 or twice per day as compared to the acyclovir. Now, what's the advantage of oral antiviral over topical? Now, there is general trend by doctors that use oral antiviral instead of the topical one, because they can reach very good concentration inside the aqueous and inside the cornea, and you will minimize the toxic effect of topical antivirals to the epithelium, so you will improve the healing of the epithelium. Also, the compliance, you have better compliance for the patient for these frequent drops. So, one of the causes of metaherpetic keratitis and delayed healing of the epithelium is the problem of epithelial toxicity, which is induced by the topical antiviral drugs. So the use of oral may be an alternative. That's why now there is general trend, because most of the doctors, they prefer to use oral, especially if you are going to use more than one drop. So you want to use antibiotics, you want to use lubricants and use antivirals, so you can keep the antiviral as oral and use the antibiotic as topical drops. So this is some information about the oral available antiviral drugs. Now, I will discuss here about the indication for the use of oral acyclovir as a treatment or as prophylaxis, and this recommendation based on the herpetic eye disease study that I will discuss about it just now. Now, the indication for oral acyclovir, number one, is the presence of active disease. Active disease means active replication of the virus, that's in dendritic ulcer or in necrotizing stromal keratitis. They found that if you use the oral acyclovir, it will reach a good concentration in the aqueous and in the cornea, and very useful in the treating of active disease or necrotizing stromal keratitis. Also, it is mandatory in immunocompromised patients. Any immunocompromised patients with evidence or history of stromal keratitis, you should keep him or treat him with acyclovir. Now, if you have an iritis which is not responding to steroids, as a result, as you know, the iritis is due to problem of the autoimmune system and the loss of the surveillance of the immune system, so that you treat him with topical steroids, but no improvement. So there is some evidence that the use of oral acyclovir may improve the case. Also in infants, because they are immunodeficient, so you have to use oral acyclovir, or in significant primary herpes simplex virus infection. So even in a primary herpes simplex with severe primary herpes simplex, you should use oral acyclovir. Now, what are the indications for prophylaxis? As I said before, there are reports document the reactivation after LASIK and PRK. So prophylactic doses of oral acyclovir before and after the procedure is recommended. Same thing for the cross-linking. Maybe the role of ultraviolet in the activation of the virus, so you have to use it before and after cross-linking. There are some reports that people who are using prostaglandin analogs as anti-glaucoma treatment, they are prone for reactivation of the herpes simplex, but this is a controversial. Also, before and after keratoplasty, when you do a keratoplasty for a patient with history of herpes simplex, you have to keep him on a prophylactic doses of oral acyclovir. Finally, patients with single-eyed patient with history of herpes simplex, better to keep him in prophylactic doses so that prevent the recurrence of herpes simplex infection in a single-eyed patient. So this is the indication for treatment as well as the indication for prophylaxis using oral acyclovir. Now we come to the surgical management of herpetic keratitis. In spite of the different antiviral applications available in the form of topical or oral antiviral, sometimes the patient is not improving and we need to have a surgical intervention either to arrest or stop the progression of the disease or to improve or treat the sequelae of the disease in the form of scarring, opacity, and reduction of the vision. Now, in the top of the list is the tarsorrhaphy. Tarsorrhaphy promotes the healing of the epithelium, and this is especially useful in the presence of metaherpetic keratitis or neurotrophic keratitis. So we can do a temporary tarsorrhaphy or permanent tarsorrhaphy based on the case. Also, we have a conjunctival flap and amniotic membrane graft. Now, this conjunctival flap and amniotic membrane, the disadvantage that it will promote neovascularization of the cornea, and this might make the subsequent keratoplasty endangered. However, it promotes the epithelial healing and it contains some important enzymes that help in the healing and prevent melting of the stroma. Now, other option or the surgical method is keratoplasty, either in the form of penetrating lamellar or Descemet's membrane keratoplasty. Of course, this should be preceded and followed by oral prophylactic oral antiviral drugs, because high chance of recurrence of the virus within the graft, especially if you use steroids after the graft itself. And that's why some doctors advocate not to use steroids. We have to use oral antiviral along with immunosuppressive drugs like cyclosporine instead of steroids. In this slide, in this picture, you can see the recurrence of the herpetic dendritic ulcer in the graft itself. And this is one of the complications of keratoplasty in a patient with history of dendritic ulcer before. So the complication of transplantation can be rejection or recurrence of the dendritic or herpetic disease in the same graft itself. Sometimes you will have persistent epithelial defect, corneal melting, secondary infection, and graft failure. So you should take care of these complications and inform the patients, and you should take care of for the prophylaxis to avoid such complications. Now we come to an important study known as the herpetic eye disease study. Number one, we have two studies, number one and number two. Number one is further subdivided into three trials. The first trial to study the efficacy of topical steroid eye drops in treating stromal herpetic keratitis in conjunction with topical antiviral. So the use of topical steroids in conjunction with topical antiviral, this is the first trial. The second trial to study the efficacy of adding oral acyclovir to the same regime in the treatment of stromal keratitis. And when we say topical antiviral, we mean trifluridine, not the acyclovir, because the acyclovir is not FDA approved in the United States. Now, the third trial is done to evaluate the efficacy of oral acyclovir in treating herpetic simplex iridocyclitis, not keratitis, iridocyclitis in combination with topical steroids. So we have three trials. The first trial, the use of steroids along with topical steroids along with the topical antiviral. The second trial, the addition of oral antiviral. In the top, that is the acyclovir, oral acyclovir, in the top of topical antiviral trifluridine and topical steroids. The third trial is the addition of or the usefulness of oral acyclovir in treatment of herpetic uveitis. Now, what are the results? Now, if we see in the first trial, that's the use of topical steroids along with the topical antiviral trifluridine, they found that the addition of topical steroids in stromal keratitis will fasten the resolution of the disease and lower the percentage of treatment failure, that is exaggeration or there is no response, and immediate corticosteroid treatment was not required for better visual outcomes. That's to say that you need not to start the steroids immediately after you start the antiviral. You can wait for some time, and then you should continue the medication, and the tapering should be done over 10 weeks. This is very important. So the usefulness of using topical steroids along with topical antiviral in stromal keratitis is well documented in this study, provided that you will start the steroids a few days after the start of the antiviral, and you will continue steroids for at least 10 weeks. Now, when we look to the second trial, which is the addition of oral acyclovir onto their same regime, that's the topical trifluridine along with topical steroids in stromal keratitis, they found that there is no statistical difference in the addition or improvement in the case when we add oral acyclovir. So since you are using the topical trifluridine, addition of oral acyclovir will not add any further improvement or resolution. Now, when we look to the third trial, which is the use of oral acyclovir in the treatment of herpetic uveitis, they found that the oral acyclovir may be beneficial in herpetic iridocyclitis. So it has a good effect. That's why when we come to the treatment, we will speak about the dose of acyclovir in the presence of active disease, as well as in the presence of or in as a prophylaxis, either prophylaxis for recurrent keratitis or prophylaxis from iridocyclitis. So this is the end result of the herpetic eye disease number 1. Now we come to the second study of the herpetic eye disease study. Now, as we have done in the first study, the second study also contains 3 trials. The three trials here regarding the epithelial keratitis. So the first trial compared the usefulness of use of oral acyclovir in epithelial keratitis or epithelial ulcer, that's dendritic ulcer, and whether it is useful in the prevention of development of stromal keratitis or iridocyclitis. The second trial was to evaluate whether a low dose of acyclovir is useful in preventing the recurrence of the herpetic simplex keratitis, either in the epithelium or in the stroma. And the third trial just to evaluate the effect of psychological, environmental, and biological factor for the recurrence. That's the stress and the ultraviolet and so on. So if we look to the first trial, that's to evaluate the use of oral acyclovir in dendritic ulcer to prevent the occurrence of stromal keratitis. The recommendation claims that there is no benefit in adding oral acyclovir in the prevention of progression of progression of epithelial keratitis to stromal keratitis or to iridocyclitis. So the risk of development of stromal keratitis is related to the history of the patient, that he has a previous attack of stromal keratitis. Now, it doesn't make difference that if you have a patient with dendritic ulcer, if you give him oral acyclovir, there will be no difference if you give him oral acyclovir or not to prevent the occurrence of stromal keratitis. The risk of stromal keratitis is related to the previous history of stromal keratitis. This should be very clearly. Now, the second trial that they evaluate a low dose of acyclovir in the prevention, regarding the prevention and the prophylaxis from herpetic eye diseases, that's the epithelial keratitis or stromal keratitis. They found that the acyclovir significantly reduces the probability of recurrence of herpetic diseases, and it has been found that there is a reduction by 50% of the occurrence of herpetic eye diseases after the use of oral acyclovir. So we use oral acyclovir along with topical acyclovir for many reasons. Number one, it found to increase decrease the chance of recurrence. This is very important. Now, if I give you an MCQ that we use oral acyclovir to increase the healing of the epithelium, this is wrong. To increase to prevent the occurrence of stromal keratitis, this is wrong. We use oral acyclovir to prevent the recurrence either in the epithelium or in the stroma. Also as a prophylaxis for trabeculitis or iridocyclitis. This is the indication of oral acyclovir. Now, the general trend by doctors is to use oral acyclovir instead of the topical acyclovir, because the topical has a problem with epithelial toxicity that retard the healing of the epithelium. Also, it has a problem with the compliance, that you need to use it for 5 times a day. So the use of oral acyclovir, as the studies showed that the high concentration of the drug will be found in the cornea, so the use of oral acyclovir may be suitable in patients with dendritic ulcer or stromal keratitis as compared to the topical drops. This is number one. Number two, sometimes when you have no clear evidence that it is viral keratitis and the picture is mixed for you. You are confused between bacterial, for example, and viral keratitis. So to avoid the toxicity of the epithelium by adding topical antivirals, so you use a systemic antiviral and topical antibiotic. So you will cover both antibiotic and antiviral. Now, the herpetic eye study also failed to explain the relation with excimer laser, that cases they found that they exacerbate or reactivated after excimer laser or after cross-linking. The study does not answer this question. Also, the study does not answer the relation with the newly emerging drugs. As I explained before, the study done on a trifluoridine as a topical drops and oral acyclovir. Now, there is a newly emerging drugs like the valcyclovir and famciclovir and ganciclovir. All these are not tried in this study. So a further detailed study is needed to answer these questions. Now we come to the conclusion of the herpetic eye disease study, and this is very important for you as a postgraduate and as a clinician. This is the location for oral questions and the MCQ as well. Now, the addition of oral acyclovir along with the topical steroids and topical antiviral is not useful or doesn't have additive effect to the treatment of stromal keratitis. And this is what we say in the herpetic eye disease 1. That if you already keep the patient on topical steroids and topical antiviral trifluoridine, he already have stromal keratitis, addition of oral antiviral will not have any additive effect. This should be clear. Although the use of steroids are very beneficial in the treatment of stromal keratitis, this is approved by the study. Also, the results are not statistically significant, but suggestive of possible effect of oral acyclovir in the treatment of iridocyclitis. Now, if you have a patient with iridocyclitis, so in these patients, the use of oral antiviral is useful in these cases. Now, in patients with epithelial keratitis, a 3-week course of oral acyclovir has no apparent benefits in preventing stromal keratitis or iridocyclitis. And this is also we mentioned in herpetic eye disease number 2, that if you have a patient with epithelial keratitis and you think that if you keep him an oral antiviral, you will prevent the progression of the disease to stromal keratitis or more severe iridocyclitis, this is not the case. So there is no role of oral antiviral in the prevention of development of severe eye disease in the form of stromal keratitis or iridocyclitis. The use of oral acyclovir prophylaxis significantly reduces the risk of recurrence of ocular and orofacial herpes simplex disease, especially in patients with the previous stromal keratitis. Now, people with the stromal keratitis, they have high chance of recurrence, unlike people with epithelial keratitis. The epithelial keratitis, there is no documentation that they will have recurrence unless if more than 2 episodes per year. However, the presence of stromal keratitis makes the patient at risk of recurrence, and these patients only they need a prophylaxis. And not only prophylaxis for stromal keratitis, but also they found that the use of oral antiviral will prevent the development of ocular eye disease or orofacial complication of herpes completely. Now, in patients with ocular herpes simplex disease, in the previous year, a history of epithelial keratitis is not a risk factor for recurrent epithelial keratitis, and this is what we have said. But the history of stromal keratitis is more serious. This has increased the risk of stromal keratitis and the risk of recurrence. And such patients, they need prophylaxis for with the use of oral antiviral. I hope with this discussion now it is very clear what's the indication for prophylaxis, what's the indication for use of oral antivirals, and the role of steroids in herpetic keratitis. Now we come to an important issue, which is the relation of herpes simplex keratitis, the recurrence, in a patient who underwent penetrating keratoplasty or lamellar keratoplasty. As you know that the main reasons for graft failure after keratoplasty in a patient with herpes simplex keratitis is either because of an immunological reaction, which is the allograft rejection, or due to an active reactivation of the viral keratitis itself, and the occurrence of the recurrence of the herpetic eye disease after keratoplasty. And clinically, sometimes it is very difficult to determine the underlying cause of the failure of the graft, whether it is due to allograft rejection or due to reactivation of the herpetic eye disease itself. I need to remind you that the complication after keratoplasty in herpetic eye disease are many. The most common is the graft rejections or the recurrence itself, as I said. Sometimes you will have a persistent epithelial defect or corneal melting, secondary bacterial infections, and at the end, there will be a graft failure. Now, the discussion regarding the management of recurrence of herpetic eye disease after keratoplasty is beyond the scope of this lecture, and we will discuss this one in the lecture of keratoplasty. However, just I mentioned this point from the point of recurrence of herpes simplex after keratoplasty cases, but the detailed discussion for the management will be considered or discussed in the keratoplasty lectures. Now, as far as the recurrence, the study shows that patients who have ocular herpetic infections before have a higher incidence of allograft rejections, as well as the recurrence of the same disease in the graft itself mentioned before, especially those who are not receiving prophylactic oral antiviral treatment before doing the keratoplasty. And the incidence has reached up to 50% within the first 2 years. That is, patients who have herpetic eye disease, they have a chance of recurrence of the same disease in the graft within the first 2 years up to 50% in the cases, and this is very high percentage. However, those who receive the prophylactic antiviral, oral antiviral treatment, they have an inverse relationship along with the duration of the use of the prophylactic oral antiviral. If the patient uses it for 3 weeks after the surgery, the incidence will be dropped down to 30% of recurrence. And for 3 months use of oral antiviral, the incidence will drop down to 18%, and so that by 1 year, the incidence will be around 0% or up to 5% only. So there is significant drop in the risk of recurrence of herpetic eye disease following keratoplasty in a patient who received long duration of oral antiviral medication. However, some people, they advocate lifelong use of acyclovir because the latency of the virus is lifelong. So some people, they advocate lifelong use of oral acyclovir provided the competence of the kidneys of the patients. And the common drugs that use it for the prophylaxis is the oral acyclovir. Either we have 2 doses, either 800 milligram single dose daily or 400 milligram twice a day, at least for 1 year, at least. Or the use of oral valcyclovir, which has better biocompatibility as compared to oral acyclovir, and the dose is 500 milligram once daily. And as I said, the minimum duration for 1 year. Now we come to an important variety of viral keratitis, is the one which is caused by varicella zoster virus. It is also the same as herpes simplex, that belong to the category of herpes viruses, that's DNA viruses, and it has a common features that it has a primary infection where there is a first exposure to the virus, and the virus then becomes dormant in the dorsal root ganglia, and then reactivation takes place. Now, usually the primary infections has a benign course and usually passed without any significant complications. And the problem in the reactivation phase, when there is a reactivation, now the complications will takes place. Now, the difference between herpes simplex and herpes zoster, that in the reactivation phase, in the herpes zoster, it is a combination of both skin lesions along with the eye manifestations. Unlike the herpes simplex, when there is a reactivation, it is mainly a ocular manifestation, and there is no much of skin manifestation. This is one of the features. However, in the primary infection, both of them, they will have both skin manifestation as well as eye manifestations. So the varicella zoster virus is responsible for what's known as the chickenpox virus. This is the primary exposure and the primary infection. And when reactivation takes place, it is named as herpes zoster virus, and it is also causes shingles. So the shingles refers to the herpes zoster virus, and chickenpox refers to the varicella zoster virus. It is highly contagious disease, and it has transmission through the respiratory droplet. Usually, children are the victim for this virus between 5 to 9 years, and it has prodromal symptoms for 1 to 4 days. After that, a skin eruption of vesiculopapular skin rash will take place, and usually it will pass and the patient will heal after that. And sometimes, rarely, even after a primary infection, there will be super added bacterial infection, and in adults, sometimes pneumonia will take place, or severe painful skin lesions due to acute neuritis. As I said, that the primary infection, usually there is no significant complications. The problem with the reactivation or the latent phase, in which there is reactivation of the virus, usually triggered by some factors. The most common is the immunosuppression. It is rarely seen in immunocompetent patients. The other risk factor is the age, usually beyond the age of 50 years, and immunosuppressed people. So another risk factor is the previous, another recent exposure to the varicella zoster. If you already sensitized to varicella zoster virus and you have another recent exposure, this might trigger the reactivation of the latent phase of the herpes zoster virus. And as I said, that it has both manifestation for the latent stage. It has skin manifestations as well as the ocular manifestations. The skin manifestation preceded by prodromal stage of burning, stabbing, and throbbing pain, and after that there will be vesiculopapular lesions with crusting and sometimes severe pain. After that, the eye manifestations and involvement will take place. Now, if we come to speak about the mechanism of ocular infection and the pathogenesis, now we can limit the pathogenesis of the herpes zoster ophthalmicus in 3 ways or 3 mechanisms, either due to a direct viral invasion itself, or due to associated secondary inflammation and what's called occlusive vasculitis. There will be associated vasculitis, or due to the reactivation of the immune system and necrosis and the inflammation that will be happens. So the damage that happens due to the herpes zoster virus is related to these 3 mechanisms, either direct invasion, secondary inflammation with occlusive vasculitis, or reactivation. Now, the direct invasion is responsible for the conjunctivitis and epithelial keratitis. The occlusive vasculitis is responsible for episcleritis, scleritis, uveitis, and also segmental atrophy and scalloping-shaped appearance of the iris, and optic neuritis and cranial nerve pulses. Also, post-herpetic neuralgia is partly due to the occlusive vasculitis, due to ischemia for the peripheral nerves, and also cicatrization and complication due to inflammation of the periocular skin and the lid and the conjunctiva. So all these due to secondary inflammation associated with the virus itself. Another mechanism is the reactivation. Reactivation will be associated with necrosis and inflammation of the affected ganglia, leading to the corneal anesthesia, and this may lead to subsequent neurotrophic keratitis. And as I said before, that the risk factor for the reactivation of the dormant or latent herpes zoster virus is the age of the patients, more than 6 or 7 decade, immune suppression, and you can predict that there will be an ocular involvement if you find the Hutchinson sign, which is involvement of the external nose due to a branch of the nasociliary nerve that supplies the tip of the nose or the side of the nose. So if you find a skin lesion at that area, you suspect that your patient might have an ocular involvement. Now, as we have said before, that the risk factors mainly related to the age, the more the risk factor. And the immunocompromised people are more prone, and people with transplantation and autoimmune diseases. Now, it's important to know the stages of the skin involvement in the herpes zoster, so that you can plan your treatment, because the management of herpes zoster, including herpes zoster ophthalmicus, is based on the early treatment. The earlier the treatment, the better the result and the prognosis. So the stages of skin involvement confined to three stages: pre-eruptive stage, which is the pre-herpetic neuralgia, characterized by pain, paresthesia along the dermatome, and headache, malaise, and myalgia. And as far as the dermatome, commonly it is respecting the midline and use a single dermatome. However, some rare cases or rare presentation in which there is multi-dermatomal involvement or disseminated herpes zoster can involve more than one dermatome. Then the acute eruptive stage is characterized by vesiculopapular skin rash that has herbiform vesicles, and later on will be crusted erythematous, and usually involves the thoracic and lumbar area for herpes zoster. As I said, that the common area is the spinal area. And then finally, which is the chronic stage, the post-herpetic neuralgia. And this pain characterized by severe pain and fibrosis of the skin involvement, and severe scarring, and can last for a long time. So as you can see here, this is the shingles for the skin manifestations that involve the thoracic area, as the this is the commonest location for the herpes zoster. And the pre-eruptive stage characterized by severe pain, headache, malaise, and coughing, and so on. So this is the common presentation. So skin manifestation is very important for the diagnosis of herpes zoster, although there is some rare cases which is known as herpes sin or zoster sin herpes without skin involvement. We will speak about this later, but the most common presentation is in the presence of skin lesions. Now, as far as the distribution of the herpes zoster, as you know that the virus became dormant in the spinal root ganglia or the dorsal ganglia, and so when reactivated, the most common location is the spinal nerves. So it will affect the thoracic area, and this is the most common site. And as I said, it will respect the dermatome and respect the midline. And the second most common place for recurrence of the herpes zoster is the ophthalmic division of the trigeminal nerve. And among the trigeminal nerve is among the ophthalmic division is the first division, which is the frontal nerve. This is the most common site for recurrence of the herpes zoster ophthalmicus. So as you can see here, this is the distribution of the ophthalmic division of the trigeminal nerve, and you should know that the involvement of the ophthalmic division, the frontal part of the ophthalmic division, doesn't necessarily means intraocular involvement, because it involves only the skin around the eye and the side of the nose. And if there is involvement of the nasociliary nerve, which innervate the tip of the nose and innervate also the skin of the lid and the conjunctiva, and also the ocular adnexia like the uvea and the choroid. So this is what's known as the Hutchinson sign. Definitely it means that there is intraocular involvement or ocular adnexial involvement. Although absence of Hutchinson sign does not rule out intraocular involvement. So this is the distribution of the herpes zoster ophthalmicus. As I said, the most common is the ophthalmic division, and among the ophthalmic divisions, the most common is the frontal branch. The ophthalmic division has the frontal branch and the lacrimal branch and the nasociliary branch, as you can see here. So this is the three branches of the trigeminal nerve: the ophthalmic division, maxillary division, and the mandibular division. And the V1 is the ophthalmic division, is the most common site. Now, as I said before, that sometimes there is no respect for the dermatome, as seen in what's known as disseminated herpes zoster, especially in immunocompromised patients. So you will find the shingles will be distributed over a large area of the skin, or what's known as multidermatomal herpes zoster, in which more than one spinal nerve is involved. And this is dependent on the immunity of the patient, as I said. So sometimes it is confusing for you, but you should not stick to the idea that only a single dermatome is affected in herpes zoster. Here, I like to mention about the zoster sena herpes, which is a unusual presentation of herpes zoster, Now, if you face a question that is it necessary and mandatory for herpes zoster to have a skin rash or skin lesion, the answer should not be yes, should be no, because very rarely, sometimes you have herpes zoster without skin manifestations, and this is known as zoster sena herpes, and also known as Ramsay-Hunt syndrome, and is a typical presentation where the vesicles rash they don't develop in the skin, and usually due to involved with the geniculate ganglia. So the patient will present with facial palsy, ipsilateral facial palsy, and vesicular rash. Sometimes you find in the around the ear, or also in the hard palates. But I just like it to mention it here because sometimes someone will ask you, is it mandatory for herpes zoster to have skin rash? The answer should be no, and the reason is the zoster sena herpes and the Ramsay-Hunt syndrome. Now we come to the clinical manifestation of herpes zoster ophthalmicus, and the manifestation mainly concentrated in the cornea. Of course, any structure in the eye can be involved by herpes zoster. There is no any structure immune against herpes zoster ophthalmicus. They say that perhaps only the liver that might be protected or immune against herpes zoster in general in the body, but any structure in the body can be involved by herpes zoster, and even in the eye, any structure of the eye can be involved. But the most common finding and complication is concentrated in the cornea. And it has an acute course and chronic course. The acute course can be in the form of punctate epithelial erosions, as you can see here in this picture, which is stained with fluorescein. This punctate epithelial erosion, just an epithelial defects that might coalesce together and form what's known as pseudodendrites, which is branching arborizing that differs from the true dendrites in the herpes simplex by the absence of terminal buttons, and there is no pulps at the end of this branching epithelial defects, which is stained very well with fluorescein. The other thing is the presence of nemular keratitis. Nemular comes from the name coin, and it is subepithelial infiltrate, usually mild haze, underneath the punctate epithelial erosions. This signifies nemular keratitis. It might be different, it has a differential diagnosis with subendothelial infiltrate as seen in adenoviral keratitis. The other thing is that the presence of keratouveitis and endotheliitis, and they respond well to topical and systemic steroids, and also with systemic oral antiviral. Now, the other thing is disciform keratitis is not that common, disciform keratitis as seen in herpes simplex, but it can be seen also, especially in the chronic course. This is example of keratouveitis. It can severe keratic precipitates and severe haziness inside the anterior chamber. Other ocular manifestation of herpes zoster ophthalmicus, of course, the conjunctivitis, which is usually associated with lid margin vesicles, episcleritis, scleritis, and sclerokeratitis, and they usually respond well to non-steroidal anti-inflammatory, and topical steroids should be avoided in such cases to avoid melting of the sclera. And the chronic course can take the form of neurotrophic keratitis, mucous plaque keratitis, nemular keratitis, and rarely disciform keratitis. Disciform keratitis is very rare in herpes zoster as compared to herpes simplex. In this slide, I will show you that no structure inside the eye is immune against herpes zoster. Herpes zoster can involve any structure of the eye. Of course, the most common affection is the anterior segment, namely the corneal involvement and the conjunctiva. However, no structure is immune against herpes zoster, and any structure can be involved and different presentation can be there. So if anybody asks you about herpes zoster involvement of the eye, you can close your eyes and say whatever you know of diseases of the eye, and the answer will be correct. You can say trabeculitis, optic neuritis, retinitis, vitritis, uveitis, whatever you know, it is correct. But now, if you ask you what's the common presentation, the common is the presence of corneal pathology. So as you can see, the most common is the prodromal stage, which can last up to 10 days before the occurrence of the skin lesions, and the prodromal stage characterized by painful skin rash and vesicles, and as I said before. Now, within weeks, the ocular involvement can take the form of eyelid involvement, conjunctiva, scleritis, episcleritis, keratitis, and also involvement of the secondary glaucoma due to trabeculitis, and also the anterior chamber-like uveitis. And after a few weeks to months, rarely posterior segment involvement is very rare. However, if it occurs, can take different forms in the form of acute retinal necrosis, optic neuritis, neuritis or optic neuropathies, and vitritis, and nerve pulses, different nerve pulses. And at the end, as I said, many complications can happen due to herpes zoster ophthalmicus, including CNS involvement, and the eye as a sequelae can be affected by the central nervous system involvement, and also neurotrophic keratitis and lipid dystrophy of the cornea, and all these complications can happen. But the most common is the acute corneal pathology in the form of dendritic or pseudodendritic ulcers, and stromal keratitis, and uveitis, and trabeculitis. And it should be reminded here that glaucoma can happen, and this is usually due to associated trabeculitis. Now we come to the management of zoster ophthalmicus or herpes zoster ophthalmicus. Now, the mainstay that the earlier the initiation of the treatment is, the better the result and the less the complication. The treatment should be initiated within 72 hours after the onset of the prodromal manifestations or the skin rash. And the mainstay of treatment is the use of oral antiviral, sometimes topical antiviral, and also in combination with topical steroids in some situations, like in the presence of uveitis or keratitis. Topical steroids should be avoided in the presence of scleritis, and instead you can use non-steroidal anti-inflammatory. And the doses of the oral antiviral as the therapeutic high dose of acyclovir 800 milligram 5 times a day, or the valcyclovir 1 gram 4 times a day for 2 weeks. Also, this can be shifted to the low dose therapeutic low dose, which is 400 milligram, can be continued for long time. Now, the systemic steroids is controversy. Some show improvement of the dermatitis and the acute pain in herpes zoster ophthalmicus, but may increase the risk of complication of mucus of plaque keratitis. So this is the drugs which is used mainly in summary, especially in immunocompetent patients, is the dose of acyclovir and the famciclovir and valciclovir, watching into the side effect. And if the patient is immunocompromised with extended dissemination of the herpes zoster or neurological complications, you can use IV acyclovir or use the foscarnet, keeping in mind the risk of renal insufficiency in these cases. Now, as I said, that the treatment should be within 72 hours to reduce the incidence of complications. And they found that if you use it within the 72 hours, the complication will reduce from 50% to 30%. And also the in combination with topical steroids and pain killing. Now, the other aspect of the management is the prevention. Now, we have to use certain vaccines and prevention of herpes zoster in general, especially in susceptible patients, those who are immunocompromised, or in old patients, to avoid the latent and remote complication of herpes zoster. And we have two vaccines, the live attenuated vaccines, the zoster vaccine, which has effectiveness of 51 to 70%. But this live attenuated vaccines, the disadvantage that it has a short time, should be kept frozen, and should be used within 30 minutes after dissolution, and should not be used in immunocompromised patient, as this is a live attenuated vaccine. And the recombinant zoster vaccine, or the non-live attenuated, has better effectiveness up to 97%, and it has long duration of validity up to 6 hours, and it need not to be frozen. It can be used in the refrigerator without being frozen, and can be used in immunocompromised patients. So now this is the best one available, is the recombinant zoster vaccine. This is very important in the prevention. Now, the discussion or the question regarding the use of these vaccines during the active inflammation of the herpes zoster, also this is controversial. It is advised to stop all the medications, especially steroids, and at least after complete recovery of the patient, you can use these vaccines. You cannot use them in the acute active stage of the zoster virus. Here, I would like to mention some important points regarding herpes zoster ophthalmicus, which are important for postgraduate student as an MCQ questions or in the oral exam. That the incidence of herpes zoster increase with age, and above the age of 60, around 15 to 20% the incidence, and by the age of 75, it reaches up to 50% and up to 75% in immunocompromised patients. And the incidence for herpes zoster ophthalmicus among herpes zoster patients is between 15 to 20%, and those without intraocular involvement. However, those are nearly 50% of herpes zoster ophthalmicus will have nasociliary involvement and ocular involvement, mainly the anterior segment. And as I said before, that the posterior segment involvement is very rare. So as you can see here in this demonstration, that the only 20% of herpes zoster cases will have herpes zoster ophthalmicus, and 50% of herpes zoster ophthalmicus will have anterior segment involvement, and only 25% they will have chronic sequelae of the herpes zoster ophthalmicus. Now, the posterior segment involvement, as I said, is very rare and may take the form of vitritis or neuropathies, optic neuropathies, retinal diseases, retinal necrosis, cranial nerve pulses, and orbital fissure syndromes. The most common cranial nerve or motor cranial nerve pulses is oculomotor nerve, followed by the abducent nerve, and the least common is the fourth cranial nerve. Now, the time to speak about the third common type of keratitis, which is caused by adenovirus. And we cannot speak about the keratitis alone. We have to speak on keratoconjunctivitis because it commonly presents as adenoviral keratoconjunctivitis. And adenovirus is also belong to the herpes group of DNA viruses that can cause keratitis, and it is one of the most common cause of red eyes due to viral origin. And it constitutes between 15 to 70% among all conjunctivitis, and there are 60 serotypes and divided to six subgroups. And the adenovirus can cause conjunctivitis along with keratitis in the form of epidemic keratoconjunctivitis, or it can just purely cause conjunctivitis as a pharyngoconjunctival fever in children or non-specific follicular conjunctivitis. For us, we'll concentrate on this one because we want to speak about the keratitis features of this adenovirus. As I said that there are 60 serotypes. The most common for adenoviral epidemic keratoconjunctivitis is serotype 8, 19, and 37. The subgroup D. The subgroup D is the most common cause. Other causes of the conjunctivitis, as I said, for the pharyngoconjunctival fever, this is the serotypes, and for isolated follicular conjunctivitis. And usually there is incubation period between 4 to 24 days, and the symptoms appears within 7 to 21 days. They can last up to 21 days, and patient remains infectious for the initial 2 to 3 weeks. And predominantly unilateral presentation. However, involvement of the fellow eye can be seen in 70% of the cases. Usually start unilateral, and in 70% of the cases it will involve the other eye, and previous history of exposure or family history or eye examination will be precipitating factor. Now, the clinical course of the disease can be biphasic, that it has an initial infective stage and characterized by active virus replication, and another inflammatory phase due to the host immune mechanism can last up to 7 to 10 days after the initial infections. And the symptoms predominantly will present with excessive watering and foreign body sensation and photophobia and decreased visual acuity. This is the main complaint of the patient, of course, apart from the complaint of redness of his eyes. And the symptoms, you will find crusting and swelling of the eyelids, and this is the signs, the crusting and swelling of the eyelids, bulbar conjunctival injections, conjunctival chemosis, follicular and papillary reactions, and subconjunctival hemorrhages. You will find petechial hemorrhages also, and follicular reactions, especially in the inferior tarsus. As you can see here, severe lid edema and redness, and conjunctival congestion with follicular reaction. Now, as far as the complications, there are different types of complication that can happen. The most common is the subconjunctival hemorrhages can be seen, and what's known as pseudomembranes formations like this one. We will speak about the difference between true membranes and pseudomembranes, which is due to deposition of the inflammatory oxidates along the inferior or superior tarsus. And also true membranes can be formed where there is new vessels also formation. The most common one is the presence of subepithelial infiltrates with granular appearance and nummular appearance like nummular keratitis, sometimes end up by symplepharon and super added bacterial infections. Now, as I said, regarding the membranes, we have pseudomembrane formation, which is a sheet of fibrin-rich oxidates and locating lacking blood vessels or lymphatic blood vessels adherent to the upper or lower tarsus, as you can see here, so that when it is removed by the button tip applicator, there will be no bleeding because there is no vessels or lymphatic, and it is just purely a fibrin oxidate seen especially in serotype 8, 19, and 37, and consists of conglomerate of WBCs and inflammatory cells along with fibrin, and no bleeding when removed. Now, for the true membrane, this true membrane formed beneath the epithelium and also contains fibrin and inflammatory oxidates along with the new vessels and angiogenesis. So this due to certain angiogenic factors, and when they remove, they will end up by bleeding, and also it can cause subepithelial fibrosis and symplepharon. The other common complications for or the hallmark of adenoviral keratitis is the presence of subendothelial infiltrate, and as I explained before, that this is due to active inflammation or replication of the virus within the epithelium, and later on it will invade deeper to the anterior surface of the stroma and will attract the lymphocytes and neutrophils and form irregularity of the surface initially, and later on will, if not healed by itself, it will end up by haziness and fibrosis of the stroma, and can be seen in 50% of the cases and commonly in serotype number 8. And it is one of the reasons of the drop in the visual acuity and the patient photophobia and tearing sensation. Now, if we study the exact pathogenesis of this subepithelial infiltrate, when the virus infects the epithelium and multiplication happens within the substance of the epithelium, it releases certain chemokines and antigens known as CXCL8. This is related to the adenovirus. And this in turn will attract the immunogenic response of the host, and neutrophils and lymphocytes will come to the location and aggregates initially within the substance of the epithelium, and then can penetrate even the pomus layer and beyond the pomus layer up to the anterior part of the stroma, and hence the name, it is subepithelial infiltrate. So it is just an exaggerated immunological response in relation or in response to the antigens of the virus. Most of the time, this subepithelial infiltrate, it will disappear by itself or by the use of steroids, but sometimes it will stay for a long time. Now, if you see in the OCT for this patient, this is very clear subepithelial infiltrate, and as you can see, this hyperreflective areas seen by the OCT, and you can see the overlying pomus layer is intact. So this is just an acute phase of the subepithelial infiltrate, and most likely it will disappear by the use of steroids. Now, if you look to this patient, similarly, he has long-standing subepithelial infiltrate and neglected. So you can see the irregularity of the pomus layer, so that this patient most likely goes into a cicatrization and fibrosis phase, and this patient will suffer from persistent haze and fibrosis within the substance of the cornea. This is the importance of the subepithelial infiltrate. Now, as far as the diagnosis of adenoviral keratoconjunctivitis, usually the diagnosis is made clinically and is evident to any examiner. However, if you want to confirm the diagnosis, we can confirm this by viral culture and the use of PCR. And there is one rapid test known as rapid adeno detector. This contains the antigen for the virus and can by the immune assay detect about 53 serotypes in just in 10 minutes. It has very high sensitivity reaching up to 88% and specificity to 91%. But as I said, that usually the diagnosis is clinical and we need not to go to the laboratory diagnosis unless in special situations in which there is no improvement or in associated with immunosuppression. Now, as far as the management of adenoviral keratoconjunctivitis, there are certain general measures include the cold compress and limit to exposure to avoid contamination to others, and also the use of lubricants like artificial eyes and some topical analgesics, and sometimes prophylactic antibiotic if there is severe super added bacterial infections. Now, the role of steroids, we will speak in details about the use of role of steroids and steroid substitutes. However, the low potent steroids like FML can reduce the scarring in severe cases, also reduce the patient discomfort and reduce the duration of the symptoms. So this is the role of steroids. There are certain indications for the use of steroids, otherwise should be avoided initially because this might increase the virus shedding. Other alternative for steroids whenever there is any contraindication for steroids, like the use of topical cyclosporine, is effective especially in the presence of subepithelial infiltrate and also during the chronic phase of adenoviral keratoconjunctivitis. So there is some general measures and some measures to reduce the discomfort by the use of certain analgesics and topical steroids and cyclosporines. As I said, that the role of steroids, especially in acute phase, is controversial. However, there are certain proved indication for the use of steroids in restricted cases in which there is some complication. For example, the presence of pseudomembranes. This necessitates the use of topical steroids. Also, the use of the presence of subepithelial infiltrate, especially involving the visual acts with marked diminution of visual acuity. Preferably, we use low-potent steroids. Also, in severe symptomatic cases like photophobia and foreign body sensations. This is the only indication for steroids. However, in a simple, straightforward cases, better not to use steroids. As I said in the previous slide, this is the known indication for the use of steroids in the presence of severe subepithelial infiltrate involving the visual acts with marked diminution of the visual acuity, or severe symptoms with marked foreign body sensations, or the presence of pseudomembranes or membrane formations. So at these situations, we can use steroids. There are certain new modulation for the modalities of treatment of adenoviral keratitis, like the use of combination of povidone iodine solutions 0.4% along with dexamethasone 0.1 ophthalmic preparation, and also other weak steroids. They claim that it speed up the recovery and reduce the subepithelial infiltrate more effectively and effective in reducing the virus load and delay the viral shedding, so that the infective stage will be shortened by the use of this combination of povidone iodine solution and dexamethasone. Other drugs known as cardiotonic steroids like digoxin and digitoxins have been used along with in the treatment of adenoviral conjunctivitis, and the mechanism of action that interfere with the gene expression of the virus and block the viral DNA replication, and hence it will decrease the viral shedding. So this is known as cardiotonic steroids. Others like mifepristone and synthetic steroid also has a role in the as anti-adenoviral treatment by inhibiting the viral entry into the nucleus. These are the new modalities. The most famous one is the combination of povidone iodine solution along with dexamethasone. Now I will mention certain points regarding the use of povidone iodine solution in the treatment of epidemic keratoconjunctivitis or adenoviral keratoconjunctivitis, because this povidone is very irritant and very painful when you use it inside the eye. So you should anesthetize your patient by topical anesthetic at least for 30 seconds before you use the povidone iodine solutions. and then you place the 5% povidone iodine solutions in the inferior fornix, and ask your patient to close his eyes and move right and left so that you will disseminate the povidone iodine solutions. After that, you ask him to open his eye and wash thoroughly with normal saline for 1 or 2 minutes. This will decrease the virus load and decrease the virus shedding, and will fasten the improvement of the symptoms of the patients of adenoviral conjunctivitis. As we said before about the indication of use of steroids in adenoviral conjunctivitis, that they have some indications like in the presence of subepithelial infiltrate in the visual ax, or severe foreign body sensations, or the presence of pseudomembranes. The advantage that they will alleviate the symptoms of the inflammation and prevent the scarring and severe scarring, especially the haziness in the cornea. However, the disadvantage that they will prolong the period of virus shedding, and infection may prolong, especially in immunocompromised patients. And also due to the prolonged use, the risk of steroid-induced cataract and glaucoma is there. As you know, the subepithelial infiltrate may stay for a long time, and the prolonged use of steroids expose the patient to this risk. Also the risk of secondary inflammations. And even though the recurrence of subepithelial infiltrate has been reported in 17% of the cases, if discontinued abruptly, that's why it is advised that you gradually taper the steroids in these patients to avoid the recurrence of subepithelial infiltrate. Other common medication, as I said before, the use of non-steroidal anti-inflammatory. The advantage or the mechanism of action, as you know, that they inhibit the arachidonic acid pathway, and hence it will prevent the prostaglandin and prostacyclin formations. Also, it will alleviate the symptoms, and the advantage that they don't prolong the virus shedding, and there is no risk of cataract and glaucoma. However, the risk of corneal melting is there, and there is no significant reduction in the subepithelial infiltrate. So this is the pros and cons for the use of non-steroidal anti-inflammatory. Now, the last thing is the use what's known as the steroid-sparing agents. Other medications use it that have effect like steroid, but they not like steroids, known as the calcineurin inhibitors, like the cyclosporine and tacrolimus. Both are immunomodulator or immunosuppressant that will inhibit the T cell activity reversibly. The advantage that they will alleviate the symptoms and the symptoms of the inflammation. They prevent scarring, and there is no risk of cataract and glaucoma. However, they have delayed onset of action. They need time to start, and the recurrence of subepithelial infiltrate will appear if they stopped abruptly. That's why they need tapering, as in the use of steroids. So this is known as steroid-sparing agents. That's the cyclosporine and the tacrolimus. In this slide, I will mention some of the studies done to compare the effectiveness of cyclosporine in the treatment of subepithelial infiltrate in a group of patients after 1 month of the use of 0.05% cyclosporine treatment. In 22 eyes not responding to steroids, they have subepithelial infiltrate and not responding to steroids. They show that 81% of the cases they cleared from the subepithelial infiltrate, and 18% has decreased in the numbers. There is no systemic side effect, as you know, in the cyclosporine as compared to the steroids, and 11% they show recurrence after sudden and abrupt discontinuations. Another study to compare the tacrolimus versus dexamethasone for the same thing, the subepithelial infiltrate, in a one randomized double-blind trial. They show that the tacrolimus is superior to steroids in the resolution of the clinical signs and symptoms, and they decrease the recurrence of the subepithelial infiltrate to 7.5% instead of 15% as in the steroid group. And there is no significant rise in the intraocular pressure, and they have a mild adverse effect, as you know, burning and redness and foreign body sensations. So the use of this steroid-sparing drugs like tacrolimus and cyclosporine has significant effect, especially in the subepithelial infiltrates. بهذا القدر نصل إلى نهاية هذه المحاضرة. أتمنى أن أكون قد وفقت في توصيل المعلومة بصورة مبسطة وبشرح مبسط. And I hope that you have understood what I have explained and enjoyed this lecture. Looking forward to meet you in another lecture soon. And all references and the links for this lecture is available in front of you. I hope that I will meet you soon in another lecture. For that time, I hope that you will be safe, and thank you very much.